चल रहा?
From which side will you speak?
यहीं से.
This side?
हाँ.
मैम का नाम उधर से उठा के इधर कर, इधर वाला नाम उधर.
मेरा नाम यहाँ रख दीजिए. Good morning, everyone, and a very warm welcome to this special keynote session of the World Health Summit Regional Meeting 2025, Improving Neonatal Health, a case study from India. I am Dr. Anju Sinha, Emeritus Scientist at ICMR, and I co-chair the Cochrane India Network. As you all know, newborn babies have a right to survive and grow into childhood and to experience their full potential. Their healthy start in life is a shared responsibility of the family, community, and the government. The causes of newborn mortality include preterm birth, neonatal infections, intrapartum-related complications, birth asphyxia, and congenital malformations. Ironically enough, most of these are preventable. India has made significant strides in improving newborn health, reducing the neonatal mortality rate from 40 per 1,000 live birth in 2003 to 20 per 1,000 in 2020. The India Newborn Action Plan 2014 was developed to provide a roadmap towards attaining the goals of single-digit neonatal mortality and single-digit stillbirth rate by 2030. As an integrated strategy, it links interventions across continuum of care, from pre-pregnancy to postpartum, underlining connections between reproductive, maternal, newborn, and child health care. Several government-led programs, such as the Janani Suraksha Yojana, home-based newborn care, faculty-based newborn care, and special newborn care units, have contributed towards these gains. However, challenges remain in improving the health of the most vulnerable among the newborns, the preterm and the low birth weight infants, and disparity exists with rural areas and marginalized communities facing higher risks. The case study from India would provide critical insights into scalable, cost-effective models for neonatal care that can inform global health policies. Further integration of digital health tools for every diagnosis, telemedicine for neonatal follow-up, and strengthened referral systems can bridge the healthcare gaps. Today we have assembled here to explore with the esteemed panelists the key milestones achieved in India in neonatal health. We seek to discuss the latest evidence on key innovations for prevention of treatment of morbidity and mortality in neonatal period. We would learn from the panelists how to better use evidence in implementation of interventions and the role of advocacy in improving implementation of the known and emerging evidences to improve neonatal health in the country. Today's keynote brings together global and national leaders and public health experts who are at the forefront of designing, implementing, and evaluating evidence-based interventions that shape neonatal health outcomes. Together, we will explore multi-sectoral strategies, evidence-based innovations, and collaborative approaches that aim to improve neonatal health in India and beyond. It is my proud privilege now to welcome the guest of honor, the chair and the co-chairs for today's session, the two stalwarts in the field of maternal and child health. Our first guest of honor is Professor V.K. Paul. He is a distinguished Indian pediatrician and public health expert, currently serving as member Niti Aayog, the Government of India's premier policy think tank. He earlier served as Professor of Neonatology at the prestigious All India Institute of Medical Sciences, New Delhi. Dr. Paul has led transformative initiatives in India, such as Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, Poshan Abhiyan, the Ayushman Bharat Health and Wellness Scheme, and the INAP. He also oversees nutrition and education verticals at the Niti Aayog. Dr. Paul chaired the National Task Force on COVID-19 and the National Expert Group on Vaccine Administration for COVID-19, playing a crucial role in India's pandemic response. Internationally, Dr. Paul has served as the chair of the Technical Advisory Group on Women's and Children's Health for the WHO Southeast Asia region, and as co-chair of the Board of the Partnership of Maternal, Newborn, and Child Health. We welcome you, sir. Our co-chair for today's keynote is Dr. Rajiv Bahal, Secretary of Department of Health Research and Director General of the Indian Council of Medical Research. Dr. Bahal is a physician scientist specializing in pediatrics and public health. He headed research on maternal, newborn, child, and adolescent health at Geneva WHO 2013 to 2022, led newborn and child health research 2003 to 2012. He received honorary doctorate from University of Bergen, Norway in 2022 for contributions to maternal and child health research. His notable contributions to major innovations for newborn and child health include use of zinc in treatment of diarrhea, early initiation and exclusive breastfeeding, outpatient treatment of newborns with severe infections and immediate initiation of kangaroo mother care after birth in mother-newborn intensive care units. He has supported multi-country research studies in more than 20 countries across Asia and Africa, strengthened research capacity in 50 institutions. With over 3 decades of leadership in health research and policy at both national and global levels, research led by him influences global health policy and has the potential to save over 1 million lives annually. We welcome you, sir. Please join me in welcoming Dr. Paul and Dr. Behel to the session. To set the context for today's session, I invite our first panelist, Dr. Rodrigo Ofrin, who is the WHO representative to India since 2020. Dr. Rodrigo Ofrin comes with a rich experience of over 2 decades in public health in the WHO Southeast Asia region. Dr. Ofrin spent a major part of his career in strengthening the Public Health Emergencies Program. Before taking up his current position, he was the Regional Emergencies Director for WHO Southeast Asia region, from being involved in the response to the Indian Ocean tsunami that severely impacted several countries in Southeast Asia. Dr. Ofrin led WHO's on-ground response to Cyclone Nargis in Myanmar in 2008, the earthquake in west coast of Sumatra in Indonesia in 2009, and earthquake in Nepal in 2015. The Ebola outbreak in Liberia in 2014 and the Rohingya crisis in 2017. As WHO representative to India, he led a workforce of 3,000 personnel to support the Government of India's COVID response. Dr. Ofrin was conferred the WHO Director General's Reward on several occasions, including Individual Excellence for leading the WHO Country Office for India response to COVID-19, leading the team in Nepal earthquake, and team member of India's Integrated Health Information Platform. We welcome you, sir. As you represent the WHO, we would like to hear from you the strategic approaches for improving neonatal health outcomes in India. Thank you.
Thank you very much. Distinguished Chair, Professor Vinod Paul, Member Niti Ayog, Co-Chair Dr. Rajiv Behel, DG ICMR and Secretary, Department of Health Research, Dr. Anju Sinha, Co-Chair, Cochrane India Network, co-panelists, friends, namaskar. I am your opening batsman, but I think the stadium is not yet as filled. Not an exciting game. We are all champions for neonatal and child health. Well, with 5 years left to meet the 2030 Sustainable Development Goals, this Regional World Health Summit offers a vital platform to drive practical, scalable, and equitable solutions that accelerate progress for women, newborns, and children across our region and the world. Just this month, the United Nations Interagency Group released the 2023 estimates on maternal mortality, child mortality, and stillbirths. For the first time, the WHO Southeast Asia region reported a maternal mortality ratio below 100 per 100,000 live births in 2023. Progress was made because India made that needle move. India was instrumental in placing the entire region on track to achieve SDG 3.1, which aims to reduce the global maternal mortality ratio to less than 70 per 100 live births by 2030. This achievement is a testament to the power of political commitment, sustained investments in health, in particular primary health care, and partnerships. India has also recorded one of the highest proportional reductions in child mortality since the start of the SDG era in 2015. Along with 7 other countries in the WHO Southeast Asia region, India met the Every Newborn Action Plan stillbirth target rate of less than 12 per 100 births. I think that deserves a round of applause. As I came to this position, the estimates, the global estimates for maternal mortality for India was actually at 140 per 100,000. Now it's at 80. So that's 5 years. And I congratulate the government of India, state leadership, of course, and technical support and implementing partners, all of you who are also here for this remarkable progress. Subnational success stories from across India further affirms this progress. By 2020, 6 states had achieved the neonatal mortality goal of 12 and less per 1,000 live births. These numbers represent lives saved, futures protected, and families preserved. The progress we celebrate today proves that achieving SDG targets is possible and within reach. With every woman, every newborn, everywhere, the partnership highlights evidence-based interventions that save lives of mothers and newborns and provides clear national and subnational targets. The remaining challenge for everyone around the world is not the lack of knowledge, good practice, or sharing these. It is executing them in different contexts. There are tribal areas, there's the dynamic urban settings, there are mobile populations. All of these contribute to where the last mile will be, and it changes. We now need consistently high coverage of these life-saving interventions combined with an unwavering focus on quality, equity, accountability, and digital innovations implemented within strong health systems. Less looking at the targets as a vertical, but through a health system. As we move forward, I think the strategic focus is about subnational strategies designed and implemented with local participation to address inequities in care. It's monitoring the intervention coverage, tracking mortality trends, and identifying at-risk populations to ensure that every resource reaches where it's needed most. It's important to track, but also to course correct, to analyze fast so that our strategies are defined and targeted so that the problems don't grow. Strong primary health care rooted in communities and seamlessly linked to higher levels of care, as is being done through Ayushman Arogya Mandirs, or health and wellness centers, through e-Sanjeevani systems, the telehealth systems, through UWIN, the universal immunization platform out of COVID, bringing that all together so that no one is lost in the healthcare referral system. Building a competent and skilled health workforce. This continues to be this needs to be a continuous investment where midwives, community health workers, nurses specialized in newborn care, and allied professionals are trained, equipped, and supported in the numbers needed to meet the demand for quality services. Creating resilient health systems to ensure continuity of care in the face of challenges posed by pandemics, climate change, and natural disasters. Harnessing technology and innovation to expand the use of digital tools. I think all of this together has to come down at the grassroots, at primary health care, and throughout the health system, so that we achieve almost zero deaths of mothers, as well as neonates and children. For us at WHO, we continue to actively assist India in its efforts to reduce neonatal mortality together with partners. We have ourselves reorganized our programs to focus on impact at the block level, supporting the aspirational block programs to strengthen last mile service delivery and quality care through technical on-ground support to selected districts. Strengthening midwifery education for improving the overall quality of maternal and newborn care through a central coordinating unit and training of midwifery educators. Providing online platform for the maternal and perinatal death surveillance and response system to advance data-driven action for maternal and newborn health. Promoting nurturing care through a capacity building package for small and sick newborns, and coordinating the revision of the home-based newborn and young infant care program. Further, the WHO National Public Health Support Network of 2,700 personnel supported by the Government of India continues its efforts to have no zero-dose children, meaning every child immunized anywhere they are. When India succeeds, the world moves forward. And this is what we have seen in this area of maternal, newborn, and childcare. Growing challenges also continue to move forward. So we have to continue to adapt our strategies with this. There are no clear answers as of yet, but from climate change, extreme weather, rising cost of living, economic instability, threatened child survival, and maternal well-being. Now we need even greater effort and sustained investment than ever before. All of us present here, as public health professionals, researchers, clinicians, and advocates, are at the heart of this momentum. Your insights, your collaboration, your commitment will shape how we close the gap. This Regional World Health Summit is an opportunity to renew our commitment and combine forces for a healthy future. Thank you.
Thank you, Dr. Afreen. Our next panelist is Dr. Janvi Nilekani from Astrika Foundation. Dr. Janvi Nilekani is a public policy professional working in maternal health. She is a 2018 alumna of Harvard, where she completed her PhD in public policy and holds a 2010 BA cum laude in economics and international studies from Yale. In 2019, she founded Astrika Foundation, supported by Nilekani Philanthropies. Astrika Foundation strives for India-wide improvements in the quality of maternal health care through capacity building initiatives and professional midwifery training programs. Dr. Janvi founded Astrika Midwifery Center in 2021, an interdisciplinary birth center in Bangalore, which provides ethical, evidence-based, respectful maternity care. Welcome, Dr. Janvi. So, given your foundation's extensive work in transforming the birthing experience and promoting evidence-based maternal care, we would like to hear from you how can the integration of professional midwifery and capacity building initiatives contribute to improving neonatal health outcomes across diverse healthcare settings in India. Thank you.
Sure, thank you so much. So at Astrika Foundation, we do several programs. One is focused on capacity building, so both theoretical knowledge, but also role play, simulation, and others. So through these programs, we work on capacity building of the existing healthcare cadres, be it ANMs, GNMs, ASHAs, doctors, so forth. But today I'd like to focus on another of our programs. We are one of the partners, along with many others in this room, who are working on introducing a cadre of professional midwives in India. As many of you may know, that in 2018, the government of India introduced a professional midwifery cadre concept. And there are national midwifery training institutes where midwifery educators are trained, such as the one at Fernandez in Hyderabad. Astrika is operating one with government of Karnataka at Vani Vilas. There is one at Sevagram in Maharashtra. So at these national midwifery training institutes, educators who are often nursing college professors or other experienced nurses from India are trained by international midwifery faculty to become educators. The educators are going on to train midwives at state midwifery training institutes. So in the last, I think it's been 7 or so years, despite COVID, this program has really rolled ahead with multiple NMTIs are operational across the country, as well as several state midwifery training institute, and increasing number of midwives on ground, especially in states like Andhra Pradesh, Telangana, and to a great extent Karnataka now as well. So professional midwives are nurses who, in the Indian system, professional midwives are those who have finished a nursing credential, either a GNM or a BSc, and have gone on to do at least 18 months of specialized midwifery training. And they are called, they have the scope and the title of nurse practitioners in midwifery. Introducing this midwifery cadre can help in improving neonatal health in a number of ways. One is, of course, the simple, straightforward, that you are increasing the capacity of the healthcare system by introducing an additional cadre of trained and specialized healthcare providers. Having a cadre of midwives enhances the system's ability to deliver high-quality intrapartum care, outpatient as well. In certain areas, there's a shortage of obstetricians. In other areas, you may not necessarily exactly have a shortage, but the capacity of many of the large hospitals is overwhelmed. The numbers are larger than capacity, and introducing midwives frees up resources in those settings. Midwives, the way the program works in India, the way the government is thinking about it, is that midwives currently are mostly practicing in MLCUs, midwife-led care units, inside high-volume top-notch government facilities. So for example, in Karnataka, there are midwife-led care units in Vanivilas, Karnataka's largest hospital for women and children. There's one in Cheluamba. So these are large institutions which have a midwifery unit inside. So having low-risk mothers go to midwifery units also frees up high-intensity resources of neonatologists and obstetricians to ensure that they can be more focused on high-risk cases to ensure higher quality of care. Having the midwives also enables low-risk women to get more personalized and more attention. The overall, introducing midwives improves the ratio of care providers to staff, which enables better care intrapartum, which of course then improves the health of neonates. Apart from the capacity increase aspect, midwifery as a career itself has a number of principles which do enable and enhance neonatal health. Midwives' approach tends to be to assume that ovulation largely works and to interfere when needed rather than to follow a medical model of aggressive management of labor. This often does lead to better outcomes for babies. As an example, there's research done in Uttar Pradesh using the data from the Better Birth trial that the augmentation rates with oxytocin in intrapartum is used so freely that the fetal distress rate baseline was something like I'm not sure I remember the numbers correctly, but I believe it was 10% in the control. And then the training program with the nurses in PHCs in Bihar, they reduced oxytocin, liberal oxytocin usage, and that and fetal distress rates came down to 2%. So the kind of midwifery approach of do no harm first and interfere when needed itself is often protective of neonates. And of course, the focus midwives have on both the emotional and well-being of the mother, but also on early initiation and establishment of breastfeeding, again, directly enhances neonatal outcomes. We're proud to be part of this program. I think many of the partners are also here today, and I'm looking forward to the panel. Thank you.
Thank you, Dr. Janvi, for your experiences from the Astrika Foundation. So our next speaker here is Dr. Carla Soares-Weiser from the Cochrane Central, the main driving force behind this strategic partnership between the Cochrane and the World Health Summit. Dr. Carla is currently the acting CEO of Cochrane, the world's most trusted producer of scientific evidence, and co-led of the Evidence Synthesis International Collaborative, an initiative supported by Wellcome Trust. She has authored more than 33 Cochrane systematic reviews and has served as Cochrane's editor-in-chief since 2019. She has been driving transformative changes in evidence synthesis to deliver timely, high-quality, and actionable insights for millions worldwide, including policymakers and governments. I invite Dr. Carla to shed some light on strengthening strategic cross-sector collaborations in India to bridge information gaps and implement evidence-based interventions in neonatal health. Welcome, Carla.
Thank you very much. And I just want to start by thanking the organizers and especially the people from Cochrane India that really worked very hard to put this session together. So on behalf of Cochrane, many thanks for that. I'm just going to share a little bit of my experience in terms of Cochrane and how we actually lead to global efforts like the one that's being described here. I'm not a neonatologist. As a background, I'm a psychiatrist, so I'm speaking on behalf of the organization, but without the knowledge of the neonatology that my colleagues previously have presented. I have seen successful collaboration in complex environments like the one that we have in India or in my country in Brazil, rely on three key principles: localization, stakeholder engagement, and co-production of evidence. And to bridge information gaps and implement impactful interventions in neonatal health, I think we must consider strengthening connections between national and the state health systems, academic institutions, and civil society to ensure that policy is informed both by the global evidence and by the lived experience of communities, such as an event that we're doing here today. Invest in evidence brokers, individuals or institutions training to translate complex findings into practice, context-relevant insights, and to serve as intermediaries between researchers and implementers. We also want and need to start thinking of promoting co-designed solutions where researchers, practitioners, and communities collaboratively identify problems and co-create scalable, contextually appropriated interventions. And we have to foster cross-sector partnerships, including with digital health innovators and philanthropic organizations, to improve data sharing and co-create a scalable a service that can be delivered in rural and underserved areas. Cochrane groups in India are already deeply engaged on this work, but we can go further by convening collaborative platforms such as this one, where national and international actors align priorities, identify evidence needs, and coordinate action, reducing duplication and maximizing impact. Thank you.
Thank you, Carla, for your insightful wisdom. Now, our next speaker is Dr. Meenu Singh. Technology has a transformative role in scaling healthcare. So I now invite our next panelist, Dr. Meenu Singh, who is the Executive Director and CEO at AIIMS Rishikesh and the President, Telemedicine Society of India. She heads the Department of Telemedicine at All India Institute of Sciences, Medical Sciences Rishikesh, utilizing Indian Space Research Organization technologies, and oversees the Regional Resource Center and National Knowledge Network.
Thanks.
Establishing a tele-education network across medical colleges. She is a pediatric pulmonologist and a key figure in evidence-based child health in India. Dr. Singh was the principal investigator of the ICMR Center for Advanced Research in Evidence-Based Child Health, and she also co-chairs the Cochrane India Network that has been awarded the first evidence synthesis unit by Cochrane in India. I welcome Dr. Meenu and invite her to share her views on the methods for bridging the neonatal health gap using digital tools for evidence-based community interventions. Welcome, ma'am.
Thank you, Dr. Anju. Good morning, ladies and gentlemen, honorable dignitaries on the dais, several experts in the audience. I'm going to be presenting to you bridging the health gap in Uttarakhand, which is the place where I'm working now. And we are leveraging digital tools for evidence-based community interventions. So we have a Center for Evidence Synthesis and Public Policy at AIIMS Rishikesh. And since this session is being organized in collaboration with Cochrane, and we are components of Cochrane India, I would just like to show you the Cochrane logo and see that there are two C's in this. One this, and this C. And this makes Cochrane collaboration. In the middle, there is a forest plot which shows, which is actually a product of Cochrane review, which was done many years ago by Patricia Crowley. And this Cochrane review established that administration of antenatal steroids to mothers who are in premature labor prevents respiratory distress syndrome. And this landmark Cochrane review actually translated into practice throughout the world and has saved many lives, many newborn lives. Similarly, Cochrane has done several other reviews, and we know that more than 10,000 reviews are there. And we have this Cochrane database of systematic reviews, which started with neonatal and perinatal reviews from University of Oxford, where obstetricians and neonatologists started this perinatal database of systematic reviews. And there, several reviews have grown over the years. We know that Cochrane is 30 years old, and I've also been associated with Cochrane for the last 30 years. And there are several reviews which have changed policy, and several reviews which are likely to change policy. There are Cochrane reviews which have shown that newborns can be saved by bubble CPAP. Their need for mechanical ventilation goes down in comparison to the traditional CPAP which is used. There are many Cochrane reviews which have shown the timing of clamping of cord, how it can prevent occurrence of anemia in these babies and their survival gets affected. So similarly, actually Cochrane database was originally created by neonatologists and obstetricians. Hence, it is very rich in these reviews and has guided policy of several World Health Organization guidelines as well as others. So in Rishikesh, we have the Center for Evidence Synthesis and Public Policy, which is currently housing the evidence synthesis unit of Cochrane devoted to India. And as we know, there are 9 Cochrane affiliates of all the centers of excellence, and they are all collaborating in this center, and we are collaborating with Campbell Collaboration. And Campbell Collaboration is something which is parallel to Cochrane, but it focuses more on other aspects, the social, the ethical, the aspects of access, ethics, equity. We know that several interventions are working. Cochrane has given evidence that this intervention is effective. It may or may not be cost effective. It may not be accessible to everyone. It may not be equitable. So everything now needs an equity lens before we translate. And we know that we are lagging behind in translational research. And for that translational research, we need to have policies. We probably need to have more qualitative research. And the state I come from in Uttarakhand, unfortunately, our rates are higher than the national average. And the reason is that there is lack of access. There are facilities which have been created, but they're not being utilized. And there are facilities which are being utilized. They are not quality standardized. So all these things, I think, have to be taken into account. And there are several things which have been added, and I will just be showing you some of these experiments which we have been conducting, and these are our use cases, where we have just started a helicopter ambulance service, which was inaugurated by Honorable Prime Minister of India, because the ladies in Uttarakhand have problem of access, the pregnant ladies. Sometimes they are in labor, and they are having obstructed labor, or they're having PPH, they're having APH. So all those ladies are now requisitioning these heli ambulance services, and we are transporting them to AIIMS Rishikesh. So as I said, this project was inaugurated on 29th of October by Honorable Prime Minister of India. And we have, this is called Project Sanjeevani. And we have had these women, as you can see, she's getting in IPPR with an ambo bag. And she's been transported to AIIMS Rishikesh because she was in severe distress because of obstructed labor, and she was resuscitated and later on saved. Her baby was also saved. So what I find now is the service which was created mainly for disaster is actually saving mothers and babies together. Then we have this helicopter emergency service has been involved in other rescue operations as well. But along with that, there are several other things which we are doing in neonatal and perinatal field, and devoted to that is our Digital India initiative, in which we have National Medical Colleges Network, to which we are transmitting several of these teaching sessions, and which are actually devoted to evidence-based care of newborns. We also have teleconsultation services, as was pointed out by Dr. Rodrigues, which is based on eSanjeevani, which is the national teleconsultation program. And we have several, we are acting like a hub for several spokes, and we give teleconsultation to many of these people. Another very important thing which is there in telemedicine is that you give consultation, but you don't give treatment. You have to give them drugs or agents which save those lives. Sometimes they are in need of blood, sometimes they are in need of platelets, sometimes they are in need of simple antibiotics which are not available to them. So drones is something which we introduced and in 23, and we were able to send many of these medications to the periphery, which included anti-tuberculosis medicine for a TB program, but also for newborn care. Sometimes we had to send blood and platelets. And this project also was supported ultimately by Honorable Prime Minister, who retweeted this endeavor which had gone on. And we are now having it all over in all the All India Institutes of Medical Sciences, which are there, where drone services have been added to give support to the care. So there are several other things which are there for artificial intelligence is one of them, in which we are trying to develop tools for diagnosis and treatment of various conditions. So these are some of the use cases which we have developed, which can be applied to newborn care, as well as they are being applied to newborn and maternal care. And I believe that they can be scaled up, as I was just discussing with the World Health representative from Nepal, who said that in Nepal, they were having this service for last 15 years or so. So I think India also needs to look forward to this. Thank you very much.
Thank you, ma'am, for informing us about the latest developments and use of technology in improvement of health in particular and neonatal health also. So now, to explore how evidence can effectively inform policy, I welcome our next panelist, Dr. Sally Green from Cochrane, Australia. Dr. Sally is the Deputy Head, Research, School of Public Health and Preventive Medicine, Monash University. She established the Australian Living Evidence Collaboration. Her research career highlights research synthesis and transfer into policy and practice in a range of contexts and settings. Sally is an active Cochrane reviewer and has several competitively funded research projects which aim to improve health outcomes by investigating the most effective and efficient pathway of knowledge from research results to sustained change in clinical practice and policy. Professor Green is a member of the National Health and Medical Research Council Synthesis and Translation of Research Committee. I request her to share her views on strategies to embed evidence-based neonatal interventions within health policy frameworks. Welcome, Sally.
Thank you so much, Andrew, and thank you very, very much to the organisers for having me here, esteemed colleagues, friends. I'd like to start by reflecting on how special this conference is for me. It brings together two of my worlds. I work at Monash University, as Andrew has said, and we are a founding member of the Academic Alliance around the WHS, so I'm very proud to be here in that capacity. But I also, like Mino, have worked 30 years within the Cochrane collaboration, so I feel like I bring two of my families to the stage to be here with you today. I've been asked to reflect a little bit on some of my experience around getting evidence, and in particular synthesised evidence in the form of systematic reviews, living practice guidelines, clinical practice guidelines, and policy briefs into policy. And in order to do that, I thought I would tell you about some recent work that we have done with my colleagues in Australia and particularly Southeast Asia, and some colleagues from India as well, where we spoke to a number of policymakers in the global context about what their evidence needs were and how we could make it easier for them or more accessible for them to use evidence in informing and strengthening their policy. And I thought it might be worth sharing some of the things that they told us about what would make that easier for them. And there were four key things that came out of these conversations. The first was maybe obvious but not so easy to achieve, and that is that there needs to be ready access to repositories or centres of trusted evidence-based knowledge that can come from trusted organisations such as Cochrane, WHO, WHS, the places where we would expect to be, and that knowledge was organised, synthesised and all together in one place. We in Cochrane, and particularly in Cochrane Australia, have been working in living evidence, which brings an extra layer of keeping that evidence up to date over time as new evidence or new research emerges. So the first one is access. The second thing we heard is knowledge intermediaries or brokers and the importance of this. And these are people who sit between the researchers like me and the people who are trying to implement that research into practice and policy and serve the purpose as brokers. They help people to find the evidence, they help them to contextualise it locally. The third thing we heard is that we are all humans and the work that we do is relational. So the importance of relationships, trusted relationships, and forums for establishing relationships and understanding the different worlds that we come from are critically important. Forums such as this that bring together policymakers, researchers, clinicians, civil society to be able to have the conversations, form the relationships that then lead to getting research into practice. And the fourth Fourth thing we heard, which we've heard a lot about already today, is the importance of contextualisation. Taking the research and the synthesised research and bringing it together in a way that makes it locally relevant. And the ways in which that can be done have been, for me, very well demonstrated in the WHO guideline for preterm and low birth weight infants, which I know you will all be familiar with. This particular guideline has a whole section on implementation and applicability issues, helping implementers, policymakers and clinicians grapple with some of the local context issues. Things like, is there access to the health services? What's the infrastructure like? Can you refrigerate it? Really well describing the intervention so that people can understand what are the healthcare worker needs around that. Do we have an adequately trained health workforce? Do we have the right skills? What are the implementation considerations? So the research on its own is not enough. We need also to work in partnership to contextualise that research and the evidence-based recommendations in order to make them locally relevant. Thank you.
Thank you, Sally. So our next panelist is Dr. Sunil Sazawal. He is the director of Center for Public Health Kinetics, Delhi. Sunil is a medical doctor with MPH and PhD in public health from Johns Hopkins University, with 35 years of research experience in clinical and public health research, focused on maternal and child health, infectious diseases, and nutrition. In his current role, he is Professor and Executive Director, Center for Public Health Kinetics, India, Chairperson, CPHK Global, Director Research, Medical Swami Vivekanand Subharati University, India, and Associate Professor, Retired, Bloomberg School of Public Health, Johns Hopkins University. His work in clinical and public health research at AIIMS, New Delhi, Johns Hopkins University, Bloomberg School of Public Health, WHO, and Center for Public Health has contributed to global health policy in zinc supplementation, iron, chlorhexidine cod care, rotavirus vaccine, and probiotics. He leads research groups in India and Africa and for prevention of malnutrition in first 6 months in NutriMam for management strategies for moderate malnutrition in children. We welcome you, sir. Owing to your extensive research experience in the area of probiotics, we would like you to deliberate upon the current evidences in this innovation on neonatal health and also the new evidences on neonatal, any other new technology that you would like to touch upon. Thank you.
Thank you, Dr. Good morning, Chair and Vice Chair, and ladies and gentlemen. I have been asked to talk about probiotics, especially in the newborn care, and for some of us who are not introduced to this subject, this field has changed in recent years because of the advancement of the technology, where we can, because of molecular detection, now able to characterize microbiome, and that characterization of microbiome has allowed us to understand the dynamics of the various organisms in the gut. And therefore we understand that there is a population of good bacteria, there is a population of bad bacteria, there is a dynamics of between these populations, and that dynamics can shape not only the milieu within the gut, but it does have implications for immunity, it does have implications for nutrition. And this, because of that understanding, now we are able to generate evidence of interventions and generate evidence of benefits a little better than we were previously. In context of the newborn neonatal period, one of the important things that we have to understand that it's not something new. Yes, breastfeeding still continues to be our best bet in terms of the survival and development of the baby. But over the years, what has happened is that we have changed technologies. We have gone from, a mixed environment, a sterile environment. We have gone to giving antibiotics to the mother. We have gone to, changing what was originally a natural pathway, and that has affected the development, because the newborn essentially develops the microbiota after birth. And whatever is the milieu around is affecting that. This especially holds true for very low birth weight or very premature babies, because two things that happen there is A, the use of antibiotics is more in those babies, B, the breastfeeding gets affected more in those babies. And so the effect on microbiota is bound to be higher, which then will have immune effects, and which also does lead to other complications in them. So in terms of the evidence for this this intervention, we have now substantial evidence in very low birth weight and very premature babies, where the giving of probiotics has been effective in both a reduction in terms of necrotizing enterocolitis as well as sepsis and mortality. What the current evidence shows is, if you go by the most recent Cochrane review, which has 56 studies evaluated, in terms of very preterm and very low birth weight babies, we got about 46% reduction on necrotizing enterocolitis with a lower bound of 35%. We got 24% reduction in all-cause mortality with a lower bound of 11%. And we got 11% reduction in infections with a lower bound of 3%. Now, another meta-analysis earlier, which did also, which was limited to 37 studies, but did include effect on late onset sepsis, also indicated a 15% reduction. Now, this is the story about the very preterm births. Now, the question is, in India, we have a large proportion of low birth weight babies, and what we have recently concluded, the ICMR study, which essentially was 6-center, multicentric study, looking at eliminating very low, very preterm babies, and basically looking at what happens in the middle level of the low birth weight babies. And that study just concluded, it hasn't been published, but basically indicated 25% with a lower bound of 7% reduction in PSBI. Now, obviously, now this is something that needs to go into the policy, but before it goes, there is further evidence being generated. The question there is whether it should be given to all groups of babies, or what is being done in US actually is it's recommended in all breastfed babies because of the fact that we have altered the microbiota in HMO, especially the HMO bacteria. But what is the impact on mortality in the population? So the two studies are underway. There's a large multi-country study which WHO is undertaking, and I believe there is another study in the planning in India which is being undertaken in low birth weight and preterm babies, which should then inform the policy. One other thing that I have been asked to talk about is the corticosteroids, and I see that as an example of importance of evidence, because as my colleague earlier said, that the Western literature showed a very promising effect of use of corticosteroids in very preterm babies. But when there were 3 studies done rather than, normally if you didn't have evidence-based policy, you would directly go from there to policy, and that's the problem that has happened in many areas. But because it was not done, and WHO conducted what was called as Action 1 trial, and that basically got into play that if you did an overall unscreened population of corticosteroids, it didn't have the benefit, and in fact had some problems. And then we went to Action 2 and Action 3 trials, where Action 2 trial again indicated not much of a benefit, but we are now in the process of evaluating it in the late preterm births and the role of that. So the question that I wanted to highlight that is the importance of, in the settings in which the policy is to be implemented, generating evidence to guide the policy, because not always what has been shown in the West is applicable to these settings. Thank you.
Thank you, sir, for talking about the evidence-based status for probiotics and antenatal corticosteroids. So our next speaker is Dr. Vivek. He is Chief of UNICEF in India, Dr. Vivek has 20 years of global experience working with the Public Health Department, academia, and UN agencies. He holds an adjunct faculty appointment at the Hubert Department of Global Health, Rollins School of Public Health at Emory University. Dr. Vivek is a recipient of fellowship from the Wellcome Trust, the Rockefeller Bellagio Center, and Emory University. He has been the regional editor for India for the Lancet for last 3 years, from 2014 to 17, and he is an honorary fellow of the Indian Academy of Pediatrics. Dr. Vivek, we would like to know your perspective about the Every Woman, Every Newborn, Everywhere initiative regarding unlocking the full potential of every newborn, going beyond survival to thriving. Welcome.
Thank you, Dr. Anju. Honorable chairs, esteemed panelists, and friends and colleagues. You know, at the outset, I must mention that this is a very unique setting in which we are discussing the India newborn case. We are having scientists, health service, delivery personnel, and then I see philanthropy, businesses, and I think lived experience was mentioned. So I'm sure there are lived experience of people who have worked in newborn care. Now, care beyond survival and newborn case study from India. So I know that Professor Paul, who's the chair, who's sitting here, he was part of the India Newborn Action Plan when it was started. So a lesson from this case study, when this was being done by countries in response to the global Every Newborn Action Plan, there was a scientific basis and a thought-through process with which India decided we will have the 6th pillar of care beyond survival. And that care beyond survival is the pillar which has guided India that on 25th of March, when the UN recent IGME estimates were released, and India was spotlighted as an exemplar. We in the country, I was incidentally in a meeting of the ICMR, one of the divisions, where we were discussing the quality of care for small and sick newborns. So that is the evidence that, you know, when a country like India thinks about care beyond survival, in its newborn survival policy, what it leads to. Now, 2 things very important from today's perspective. Care beyond survival for newborn. Take the India case again. Just in the public sector, the footfall in the small and sick newborn care units has crossed 1.5 million babies. Country's capacity to save more and more newborns who are small and vulnerable because of the science. For example, bubble CPAP was mentioned. That has been scaled up across the country. It is increasing. And what this is leading to, children, small and vulnerable newborns who will be vulnerable to further sequelae if the quality of care beyond survival is not there. So for that, I think this thought-through process of the 6th pillar of care beyond survival is providing the ground for looking at newer ways of reaching every child. There is a new construct called inclusive early childhood development, that while we have been focusing on the early childhood development principles, the first 1,000 days, and the recent release of the Lancet for the next 1,000 days, which says that there should be care continuum between the first and the next 1,000 days to optimally utilize this early start. What is also now important is to think about nearly 15 to 20% of the children who will be either born with birth defects or will have some sort of developmental disabilities or other issues that will need special care. So when we say inclusive ECD, we need approaches whereby the caregivers, either the frontline functionaries or the families, have the capacity to also provide early childhood development to children with special needs. For example, one of the sessions at this summit is by the Down Syndrome Federation of India, where there is a parental group of people who have children in families with Down syndrome. So there is a 21-year-old young adult who's on her own, and she's a manager in a hospitality industry. And her mother, in a recent session I heard, she said the only difference was we knew how to provide early start and care to this child. whereas there could be another 21-year-old with Downs who may be literally chained in a house because of societal issues and stigma. So these new approaches, and in terms of policy translation, India, for example, has a large ICDS scheme in which recently a protocol was released for children with disabilities, the Divyang protocol. So care beyond survival, especially in the context of India, we have scientific basis for policies and programs. Now what needs to be studied is that in the diversity of a country where the systems have, for example, the newborn mortality rate of 3 in a state to 30, how to prioritize and ensure that we are able to reach every child. Last but not the least, I must mention that the World Health Summit now is a formal Lancet commission. And the purpose of the commission is, it says, communication of health-related science and societal change. So I believe this is the kind of forum that can ensure producing not just good quality science, but also simplifying science for social movements that can lead to societal change. Thank you.
So I would now like to invite our final panelist of the day, Dr. Vishwajit Kumar, from the Community Empowerment Lab from Uttar Pradesh. Dr. Kumar is a community and health system embedded neonatal health researcher and has conducted multiple seminal research over the past 20 years, expanding the field of epidemiology, clinical trials, and implementation research. He is a recipient of multitude Grand Challenges Innovation Awards, Social Service Awards, Orations, and Leadership Awards. Welcome, Dr. Vishwajit. So introduction of Kangaroo mother care, breastfeeding promotion, and early essential newborn care has demonstrated improved survival outcomes. And the World Health Organization is in the process of reviewing the current recommendations on care of preterm or low birth weight newborns, considering the new evidence on IKMC and MNCUs that is becoming available. So what, in your view, are the challenges that are being faced by the healthcare system to make the zero separation concept a reality?
Thank you very much. Before I begin, I'd like to thank Dr. Paul, Dr. Rajiv, and Dr. Sunil in particular, because they've been my teachers and my guru. Dr. Sunil initiated me into public health. Dr. Rajiv took me under his arms. Dr. Paul has been the guiding light for me, and I'm sure Dr. M.K. Bhan watches all over us. With that sense of gratitude, I'd like to begin. And I'll focus today on my talk on kangaroo mother care, and then weave into some of the challenges that comes with it. And kangaroo mother care, unlike most of the interventions, was not born in Boston or in Oxford. It was actually born out of a radical necessity in Bogota. It was born out of deep compassion, a deep commitment, and a challenge within a context of crisis, where you had very high newborn mortality, you had overcrowded neonatal units, and you had very limited incubators, and dysfunctional ones at that. And I think KMC has come a long way since 1978. I'd like to thank Dr. Rajiv for his leadership, and I think the final guideline, the WHO guideline on the care of the low birth weight and preterm baby, I think it's a good culmination for KMC in particular. Now, when I look at KMC and its evolution, I see some of key seminal points there. One of them was, of course, the stable KMC, where we demonstrated where KMC, which was initiated in 1978, over the next 40 years of research showed that it reduces neonatal mortality by 40%. The latest one at 32%. Now, this was remarkable because it was a non-biomedical intervention that not just had impact on mortality, but also on infection, improving breastfeeding, lowering hypothermia rates. But I think the challenge was that how do you take them to scale and how do you take them to other facilities? The second, I believe, most seminal study that changed the perspective on this was community KMC that was done by Dr. Bhandari's team and supported by the World Health Organization. And I think for the first time, it showed that you can actually take this life-saving intervention right to the community in the poorest geographies of the world. And it demonstrated that you can actually reduce neonatal mortality by 30%. Now, these were very important, but yet we struggled in taking KMC where it's needed most. And therefore, in that sequence of events, I believe a third study was extremely important and contributed to our current understanding was in terms of scale, was the scale-up implementation research KMC. And I think that was for the first time it demonstrated that KMC not was just feasible within these controlled conditions where you conducted research, but was actually possible to do that within the health system settings, both within the facilities and continuing on in the community with very high levels of adoption of high quality KMC. But I think the most radical, the most transformative study that I believe in KMC was actually the immediate KMC or KMC for unstable babies. I believe that it required not just evidence, but it required a lot of courage. Because till then, the world, we said that this is the most powerful intervention that we know, but it doesn't work for unstable babies. And I think this was a study that completely broke that paradigm. For the first time, you had babies who were unstable, put on kangaroo mother care, and demonstrated 25% in neonatal mortality above and beyond what is achieved by stable babies, KMC for stable babies. Now, this was radical in many, many ways. One, of course, we know how impactful it is, but I think there is a story behind the evidence as well. You know, there was a famous American psychologist who said, if you want to truly understand anything, try changing it. And over the past 5 years, we have been attempting, and when I say we, it means Dr. Rajiv, and many researchers across the country and in the world, we have been attempting to see how we can actually scale and integrate the system. And there are some lessons I believe are very important. First and foremost, I think we need to understand that one of the reasons that KMC has not gone viral as we would have expected, particularly in the light of this overwhelming, convincing evidence, is because it's actually radical and revolutionary. It is radical because in our existing dominant paradigm of newborn care, the separation from the mother is the norm. We trust the machine more than the mother. And there is a clear hierarchy where the mother doesn't even exist. On the other hand, when you bring the mother inside the special newborn care unit or a neonatal intensive care unit, you actually completely disrupt the norm. So here you bring in a mother who could be the poorest in the world, but has the same ability to save the life of a baby as the richest woman sitting in Oslo. And I think that is radical, both in terms of biology, but it's also radical in terms of morality. And I think that's one key, but it also means that the moment you bring somebody who was just a recipient into a system and becomes a provider, it dramatically changes the relationship there. It completely redistributes the power, redistributes the relationships within the system, which means that there needs to be a reimagination of that space, reimagination of that relationship, reimagination of the care that is being provided, which also means that it also needs that in order for us to embed and scale kangaroo mother care, it doesn't just need behavior change, just like we have for any other procedures or innovations, but we need actually system change and a mindset change. And I will end, I'm looking at Dr. Vinod Paul, that this is actually very revolutionary, because here when we design a system for kangaroo mother care, then a system that does universally provide kangaroo mother care, it's a mirror, because it does not put the mother last. It's a system not designed to reach the last mother, but it's a system designed because it recognizes that the mother is all-powerful and she can be central to the care or provision for this. So these are some of my key insights from our work, and I will end that this is also difficult, or at least appears to be so, because this is not resource intensive, but because it is relationship intensive. For it to succeed, our current systems, which are hierarchy-based, have to transition to become a partnership-based. Thank you very much.
So now we move to the question and answer series. I'll pose one question to each panelist and ask for their focused response. So going first with Dr. Rodrigo Ofrin, I'd like to know you, sir, how can WHO support India in strengthening health systems to deliver equitable and timely newborn care? You have 3 minutes to answer, sir.
Thank you. Quite a challenge. Not everything is with WHO, but it is done in partnership, of course, with the Ministry of Health. I think the first is what I've already mentioned during my opening bat. It was our work around focusing on the aspirational blocks. The aspirational blocks is really a program set up with, of course, Dr. Paul, identifying 500 blocks in the country where they're a bit behind in certain social and health indicators. In the health aspects of what a block should achieve, 4 of the 7 areas are actually for maternal child health. So as a team of WHO in India, we have identified 52 blocks where we are present in 2 or 3 programs. We try to be more strategic so that we are working closely with the block. It's looking at improved service delivery for mothers. It's looking at TB, screening of NCDs, having our Arogya Mandirs, or the health and wellness centers, be certified for national quality assurance system. So that's using our whole network all over the country. That's the big part. It's really looking at how all the investments of India now serve better maternal child health. I think that's really our strategy. I'm in a very lucky position that India has so much investments. It is the largest health insurance scheme. It is the largest investment for primary health care through the health and wellness centers, all 174,000 of them since 2018, and a larger infrastructure investment. So with that also comes maybe another area of our support in terms of the health workforce, capacity building for the health workforce, studying health systems. I think that's also key. I think the evidence around practices for maternal child health should also combine with the evidence around what works in health systems. So we've done some work with identifying how PMJ, or the health insurance scheme, can be more efficient in terms of certain areas such as reimbursement. We've contributed to the standard treatment workflows that are used as a guide for reimbursement. So these should all connect. I think at the end of the day, that's where we can also support. We have provided health advice and technical support for the Ministry of Tribal Affairs. As I said, the context in which health is delivered is changing and the challenges are out there. There are increasingly areas that are flooded for longer periods, how does health services change? If there is any one constant, is that a mother will deliver, a pregnant mother will deliver. So it's how do we adapt the services so that that mother will deliver safely and the child will be nurtured from childbirth throughout its life. I think that's the end.
Thank you, Dr. Rodrigo. Thank you for your insights. Next, I come to Dr. Janvi. So, Dr. Janvi, what are some high-impact models of public-private partnerships in India that have enhanced midwifery services? One is your Astrika Foundation. Can you name any other?
Hello? Yeah. Midwifery is very new in India, so there are honestly only a handful of institutions even working on professional midwifery. Yes, we at Astrika Foundation definitely partner with the government of Karnataka at various public hospitals. We also do a lot of work with, trying to do a fair amount of work with trust hospitals, so private non-profit trusts, to establish, if not full-blown midwifery, at least more midwifery principles. I'd definitely like to talk about Fernandes Foundation. Indy is here, their director of midwifery. Fernandes was a set of private hospitals which eventually became Fernandes Foundation, and they have worked in very close collaboration with the governments of Andhra Pradesh, Telangana, WHO, and UNICEF, if I'm not mistaken. So as a private institution, they were able to pull together the facility, the faculties, the training programs, and in the early days, the curriculum, which was then rolled out both in their own hospitals, but later on in various government hospitals in these states. So I think while there has been quite a flourishing of private institutions and private NGOs contributing to establishing midwifery in public hospitals, I'd like to see a bit more perhaps of the other way around, where when midwifery when people are seeking to establish midwifery in private hospitals, somewhat more support from the public sector to enable and let that flourish would be something I hope we can move towards. Thank you.
Thank you. Coming to Carla. So Carla, being the CEO of Cochrane Collaboration, what do you think are the mechanisms to ensure rapid translation of Cochrane findings into actionable clinical guidelines at the state level?
Thank you very much, Anju. So one thing that it's clear is that Cochrane reviews are quite complex many times. Yeah. And because we have a standardized way of creating evidence, we don't do recommendations. So that's really a need for partnership and adaptation that other colleagues have already mentioned. But I think there is some initiatives within Cochrane that have improved the ability of translating the evidence. One of them is that now every single review has to characterize where the clinical trials come from, and if they don't have evidence from different regions of the world, they have to explain why. Okay. So I think this will help setting evidence that is useful, and it can be reused and reshared for adaptation. The second thing is that every single Cochrane review has a plain language summary. Yeah. And this plain language summary, it's, believe me, I've done over 60 reviews, is the most difficult part of the review to write. Because actually, you have to really think through everything and try to make sense of in plain language. My first language is Portuguese. I remember having really hard time. But we are in a moment of AI tools. And AI, we are exploring whether AI can help us to interpret the review and do this plain language summary. So I think, to me, it's clear that it needs to be contextualized. It needs the local hubs to do the contextualization. And our role is to provide information that is trusted, that it can be used for this contextualization. Thank you.
Thank you. Madam Dr. Minu Singh, so coming further from Carla's description, how can systematic reviews be adapted or supplemented to address context-specific health issues in low-resource settings in India?
Thank you very much. We know that many of the systematic reviews have shown the effective interventions, and many of them have been integrated into guidelines as level 1 evidence or level A evidence. But we really need to see what is the gap which is still existing in translating this evidence into practice. And for that, I think we need to do gap map analysis. We have launched one for maternal and child care in collaboration with Campbell Collaboration. And I do feel that integration of these modalities into Ayushman Bharat program in PMJ will also be very helpful. Although most of them are not very high cost strategies. They are low cost, but they need to be known to the effective workers, the workforce, which is working at the field level. We know that home-based newborn care is established. It can save lives. But still, people are not aware of how to do that home-based newborn care. And I think integration of Ayushman Bharat digital mission, because supporting these families through telemedicine, through video conferencing, through telephone calls, through whatever means of communication we have with them, it would really help them in adopting those strategies which can actually save lives of these newborn babies, and especially preterm babies. Because at the time when Gadchiroli experiments were done, digital was not that developed. And I think we need to make this intervention to see how quickly this would transform these interventions into practice and show us the results. So that is another area, I think, which would need strengthening. And of course, we have these high cost interventions, whichever I had shown, which are currently high cost, but I think on scale up, the cost may come down. And we need to do proper health technology assessment before we adopt many of these interventions into practice. So, their cost effectiveness, the equity issues, the access, the ethics, all these things will have to be considered. And we need to have locally developed tools to measure all these parameters. We know that there are international tools which are there, but we need to have something which is conducive, which is appropriate for Indian culture and Indian socio-economic milieu. So those are my thoughts on this.
Thank you, ma'am.
Thank you.
Sally, so as Carla mentioned, contextualization of evidence is important. So what do you think, how should we grow capacity in this area so that, the evidence is made available locally?
Thanks, Anju. I think we could talk about this all day and the number of things that we could do to grow capacity, but I think for me it comes down to sort of two key concepts, and many of them have been spoken about already. I think the first one is really embracing diversity, not only as a moral principle, but because it improves the science. So guideline teams that include people with lived experience, that include mothers, that include clinicians from multiple settings, multiple countries, as well as including policymakers and researchers and methodologists, grow capacity for everybody. Capacity sharing across multiple settings and multiple different kinds of diverse experiences. So the first one, I think, is really embracing the importance of diversity through the lens of because it improves the science. And the second one is inevitably investment, but not investment for the sake of it, but investment in a global architecture for being able to do evidence synthesis and translation work. And that global architecture, which there's work happening at the moment, as our colleagues in Cochrane, India know, they are involved in thinking about global investment in platforms, technology platforms that allow us to harness AI, make the most of the technology that we have to generate evidence more efficiently, to coordinate functions so that we're not duplicating effort, to bring people together, build teams, and of course in methods, in thinking about how we can adapt methods to enable simpler health systems related evidence to address the real questions. Thank you.
Thank you. So coming back to Dr. Sunil Sazawal. Sir, you mentioned in your talk about the neonatal sepsis and how difficult it is to treat it. Would you like to talk about some new modalities of treatment of neonatal sepsis?
Thank you, Dr. Anju. One of the things that I thought about it is that we always think of new modalities as something new. And I thought, in context of treatment of sepsis, something came up recently when we were reviewing some of the data, and I thought to mention that first as a new modality. And it's not a new modality, it is not to do something new, but not to do something. because as part of the review of, we talked about the trial, which was a multicentric trial for looking at sepsis as an outcome. So there were five centers, 5 best centers in India where we had data on actual babies being referred with PSBI for sepsis to either a outpatient setting or to a hospital most of the times. And we were reviewing this for education of the endpoint, and we had an external committee, and we went through the case records. And it was astonishing to see how many times antibiotics in sepsis are changed. Antibiotics are given for 1 day. Some antibiotic is given at a dose which is not understandable. So, and that is something, if you're asking me one most important new thing that has to happen is that practice to be stopped.
Yes.
I mean, it was really, 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 and we're trying to see that if we can publish that somewhere to get it into attention of all the practitioners, and these were hospitals. So do not give antibiotic indiscriminately. Do not give it at a dose which is, and a duration which is not correct, because that produces resistance, and that's why we have the problem of resistance. Now, for the other side of it, for the sepsis management, which we have, like I said, the practices like this have already in our environment created high resistance patterns, and that also is encouraging this pattern of jumping from antibiotic to antibiotic without understanding which is sensitive or which will respond. There are 2 or 3 newer strategies that have come up. I mean, there has been a suggestion of floxamesif and phosphomycin, which because of its properties is recommended for the resistant sepsis and would be useful. The advantage of these 2 drugs is that they are already licensed and they have already expired in terms of their patency laws. So they should be readily available to the low socioeconomic settings, should be readily available for manufacturing and distribution. The problem with these is that there is evidence at an experimental level that they are very effective against, especially in combination against resistant bacteria that cause sepsis in newborns. But real evidence from a clinical trial is pending. But what is good is that the Global Antibiotic Research Development Partnership at WHO has, in 2023, has now been given a grant by Wright Foundation. And there is a multicentric study going on, which basically is testing 2 of these drugs and amikacin with a 3-armed study, basically looking at 2 drugs at a time and looking at phase 1 and phase 2. And I think it has completed phase 1. The results should come up in next 1 or 2 years, and that should change the policy. That's something that is in the pipeline that could change the management.
Thank you, sir. So, Dr. Vivek, how do you think we can, the partnership between government, NGOs, and local communities be strengthened to ensure that neonatal interventions reach the most vulnerable populations?
Thank you, ma'am. I think this panel also provides the right opportunity to see what the nexus of 4 can do. So we have the government, which has to take things to scale. Businesses, like I see Janvi, and also many other businesses within India now are coming forward to rally and align to some of the government priorities. The civil society that can hold the other 2 stakeholders accountable for what is required for the civil society, and of course the development partners that bring in some of the global policy translations. But 2 specific examples, and again focusing on care beyond survival in India, and the 6th pillar in the policy instrument which was allowed in the INAP. Now 2 businesses in India came forward to say, we want to partner with child development centers. So in the state of Kerala, and I'll take another example of a center of excellence in neurodiversity development disabilities at AIIMS New Delhi. So the idea was to connect our growing ability for small and sick newborn care to the district early intervention centers of the RBSK, which is the Child Development Program, and how we can ensure continuity right from the preconception period, making the communities prepared for what can happen in high-risk cases with their newborns and what kind of care will be required beyond survival. So I think this kind of nexus, when India is gaining in the survival and we are being spotlighted as exemplars, if we truly have to make this, make good of this demographic dividend, but also from a moral imperative, I think looking beyond survival and these kind of nexuses are very important. And now we are seeing this happening in India. And Janvi is sitting here in the audience, so we see that example too. Thank you.
Thank you, Dr. Vivek. Coming to Dr. Vishwajit Kumar. So we talked about innovations, but would you like to shed some light on a new technology, which is the emollient therapy? Although the Cochrane review has shown a very low certainty of evidence in a Cochrane review published in 2021, it is a traditional intervention with, in many settings, claimed to strengthen skin barrier, reducing water loss, and leading to increase in weight and reduction in neonatal mortality in preterm and hospital-acquired infections. Would you like to throw some light in this innovation?
Yeah, no, thank you, Dr. Anju. I think this is another example where, just like Kangaroo Mother Care, I see them as an innovation from the global south. And I think emolliation is another practice which is universal in South Asia, even in Africa. And I think this is a practice that you don't see much in the West. And so there is this already existing ecology for emolliation. And I think the other piece of that story is I think the skin barrier is an under-recognized, under-investigated, under-evaluated conduit for therapy. And I think there are two aspects to it. You know, one, of course, is emolliation has two pieces of it. One, of course, is just the touch and the tactile stimulation, et cetera, which has neurodevelopmental outcomes. And I think within our country, this is a practice, and I think that still continues to be under-investigated, under-evaluated. The other piece of it, which of course is its impact on sepsis and mortality. We actually we did a study while Dr. Rajiv was in Geneva, and we studied over 20,000 newborns, a very rigorously evaluated study, a randomized controlled trial, and far, far bigger than any other study. And we found for all babies, it was for all babies compared to the existing norm, we didn't find any impact on neonatal mortality at all. However, when we did the sub-analysis on the smaller kids, we actually found some signals of impact. So I believe what is the biggest barrier that I see is actually irrefutable evidence. And I think that needs to be built. There's already an ICMR study underway, and I believe it should add to the evidence base. And I think that is one key. The second, even while we are doing this or starting this trial, one of the challenges that we found was standardization. So we were looking for, one of our key components there was linoleic acid, and it was very difficult for us to get within the sunflower seed oil that we had used in our previous study. So I think that would be because you have all kinds of oil with all kinds of variations, and I think that needs, so that's one piece of it. The second, I believe that emollient, if we do find impact on mortality, I think it'll trigger a whole line of research on augmenting that oil to have more effect. So it almost becomes a vehicle for more effective constituents for impact on neonatal mortality. So I would see evidence. And in terms of behavior, in fact, it's actually quite universal in many newborn care units across the country. And so I don't see that from an adoption problem, but I do see an evidence problem at this point.
Thank you, Dr. Vishwajit. I would now request our co-chair for the session to reflect on the deliberations we have had today. Sir, as a leader from ICMR now and WHO earlier, having led many multiple research groups across the globe, being a hardcore researcher yourself with your skills and knowledge in epidemiology and interest in evidence-based healthcare, you are bringing transformative changes in the field of health research in India, highlighting the importance of implementation research, setting up Center for Guideline. These are some of your new initiatives. So what, in your view, are the gaps in implementation and challenges in neonatal healthcare in the country at present? Dr. Rajiv, please.
Thank you. Respected Professor V.K. Paul, Member Niti Aayog, and all the distinguished colleagues on the dais, off the dais, ladies and gentlemen. It was indeed a great pleasure to listen to all the panelists this morning. And I was reflecting on what a transformation has happened in the somewhat, I would say, just over 25 years. Late 1990s, we were at a situation where newborn care was almost highly super specialized, high tech. There was no real program, no thinking about a population-based approach to newborn care. And then with a few people globally leading, and one of them is sitting with me, Professor V.K. Paul, they decided to say that how do we bring this issue of newborn health and newborn mortality to public health programs. And the one path to that, which has been spectacular, in my opinion, has been how evidence has really been used to lead to guidelines, policy, and programs. I haven't seen a better example of this. Maybe there are one or two others, like tuberculosis, but here, newborn health has been one such wonderful example where evidence, I'll give you a few examples. Home visits, seminal work done by Abe Bang, but then confirmed by so many across the world, including Dr. Vishwajit Kumar, Dr. Zulfikar Bhutta, many others who conducted multiple studies who showed that when you give home-based care to the newborn, you improve the practices around what the mother does and the family does for the baby, that itself reduces neonatal mortality substantively. And then the work that UNICEF has done, which was based on, again, work done in India, in Purulia by Dr. Dilip Mahalanabish and others, showing that, and in Vietnam, showing that even smallest of hospitals were able to take care of small newborns, sick and small newborns, and would change neonatal mortality. And the way that has gone in India from there is for everybody to see. The importance of, most recently, family integrated care, family centered care, not separating the mother and newborn, that very passionately Vishwajit talked about, is again testimony to showing how evidence will shape the future of newborn care and even neonatology as a discipline. I'm going to repeat one sentence from Professor M.K. Bhan. The first time he went to Safdarjung Hospital where the IKMC study was being conducted, and because of that we had to bring the mother into the intensive care unit, and he saw that maternal newborn care unit, maternal newborn intensive care unit, he said, this will change how neonatology is practiced all over the world. If not today, maybe in 20 years. Because it is just simply the right thing to do, not separating the mother, who is a guardian angel for the baby, from the baby. There is absolutely no reason why we did it, except that we had some very funny ideas that we will do better than the mother and we'll bring the mother. And there, I think, this is another example. And somebody, I think Dr. Sunil Sazawal talked about antenatal corticosteroids. There was, when it was actually tried, what was the Cochrane logo correctly, and I'll talk about Cochrane in a moment. But when NICHD, with this global network, tried to implement it in 8 countries, they actually found an increase in neonatal mortality. And that really threw us into a very difficult conundrum. What is happening here? Why that would have happened? Because it is true that when you give antenatal steroids, you will improve respiratory distress syndrome, etc. Until you really analyze that study, and we found that essentially it was being given to women who were not really going to be in preterm labor. In fact, 86% or 84% of women who received antenatal steroids did not deliver a preterm baby. In that case, so that only comes with the power of understanding. Otherwise, if you just do implementation, you would say, what is the easiest way to implement? Let everybody do it before they are referred and everything, and so on. And when we repeated this study at WHO with the right type of environment, which meant that we had to be sure that the mother was actually, the labor was in preterm, and that the delivery was imminent, that it was not something that you were just trying to think and then the delivery wouldn't happen. You again found it to be exactly the same. You had about 20% reduction in mortality. So this was for me, again, the power of, and you talked about immediate KMC, already I don't want to talk about it. Bacterial infection, I want to give one last example. And this is something that will come even more, again starting with Abe Bang's work on treating infections outside of the hospital. Because at one point we thought that you cannot treat a sick newborn outside of the hospital. And now our understanding has moved to saying you don't bring a child to the hospital if you don't need to bring a child to the hospital, because the risk-benefit ratio is only good if the child is at serious risk and very severe disease. At that time, admission to a hospital is a great idea. But a child who does not have serious disease or morbidity, and you admit the child to the hospital, you are actually putting the child at a greater risk. The benefit harm ratio is reverted. So all that comes from very carefully done research in this area. And I really think that it has changed already, the neonatal mortality in the late 90s to today. If you look at any country in the world, it has dramatically shifted. In India, it has dramatically changed. It's now getting to, many of the states are already reaching the SDG goal of less than 12. The last thing I want to say is about the power of evidence synthesis. And in so many different areas, my latest example, when we were working, I was at WHO, we were working on the guidelines for the preterm baby. All our understanding of research on probiotics was really that it depends on so many things, and the type of strain and the type of bacteria, the probiotic you use, and it is very dependent on that, and it's very difficult to actually make any conclusion until you see very plainly the entire, all the studies put together. And then you clearly see the pattern, that essentially it is a substantive reduction in mortality with 2 groups of bacteria as probiotics. And that's more or less, my feeling is that's where we will have now more confirmation, and we'll go in that area. As far as India is concerned, on the side of evidence synthesis, not only we have this Cochrane India network, but now we have enshrined the evidence synthesis into the Department of Health Research, where we have established a center for guidelines. And that center does guidelines at par with what is being done in NICE UK or what will be done in the World Health Organization in Geneva. It is doing guidelines exactly with the same class and same quality. And of course, that requires a huge network of experts, of groups that can do high quality systematic reviews. And we have established 28 such centers in the country now, which are our technical resource centers to do evidence reviews, systematic reviews in a way that are again of very high quality and high class. So we believe truly that producing evidence is critical because it has shown by test of time that how it can shape programs. Then synthesizing evidence in a systematic manner is also something that we must do, convert it into recommendations and guidelines, but then the whole question of implementing it, and there I would like to simply answer your question by saying that many times when we implement, people think that, oh, I know what to do, and they have some very smart ideas, some common sense ideas, and then they go ahead and do them. But there is no way of knowing what you did, how did it work or did it not work. So for me, implementation research provides that systematic way of looking at why we are not able to implement with high quality and high coverage, and then design solutions, but not only that, evaluate those solutions in an iterative manner to find whether we are now doing better with our implementation and we are moving towards our target, so that we can refine, review, and reiterate until we get a model of implementation that is optimal to reach the highest level of coverage and quality. So for that reason, the Indian Council of Medical Research has set up a large number of implementation research studies. One I want to mention is Sankalp. In India, it means resolve. And that Sankalp is to reduce mortality, neonatal mortality, in 10 districts of India within the next 3 years to under 10. And using all the science that we have and all our implementation knowledge, and in an iterative way, develop a model which will lead us to that kind of mortality reduction. So I really want to congratulate the organizers of this symposium, this group, and would like to say that we should continue to move in this direction. Thank you.
Thank you, sir. Now I address our chief guest. Sir, in 2020, India assessed its progress against the India Newborn Action Plan 2014 milestones and targets, and India has achieved the target for reducing newborn mortality rate to 20 in the year 2020 and reducing stillbirth rate to below 19 by 2020. So this is a proud moment for us, and we applaud your efforts and your leadership in the INAP. So now I kindly invite you, your reflections on the achievements in this area and pave the way forward for us.
Thank you, Anju. Distinguished colleagues on the dais, off the dais. I'll build a story from where Dr. Rajiv Bahal and other distinguished colleagues have left. One newborn warrior is Dr. Bahal, not only having contributed the work within India, but also globally. Is the prime mover on newborn health for 2 decades in WHO, and before that, half a decade in India, and now another very stellar period of his work at ICMR. So Dr. Bahal, very proud of you, your passion. You did many other things, but newborn was truly your passion. I think, I'll be brief because we are over time. One headline is obviously the fact that our neonatal mortality decline has been substantial, impressive, we are on track for achieving the SDG. We already have 6 states, and including 1 union territory to be specific, that's Delhi, where the SDG goal has been achieved. Urban India is at 12 in 2020. It has achieved the SDG goal, and we are sitting in 2025, I'm sure. There are additional states that have done they have reached that mark. So we are on track. What I would expect partners and scientists and our own national stakeholders to help us do is to achieve SDG in every state. So that's my first message. Nationally, we will achieve, and perhaps before 2030. Why perhaps? Most likely. Can we do it in every state? And therefore, the states where we are slow, please help us. The INAP provides us the renewed paradigm and the framework. You all have developed it. Make it happen in every state, and that's where program managers, scientists, partners, civil society, the research community, and all of us in the government would like to work together. So that's the message number 1 in this meeting. The second, I would like to compliment and truly congratulate the Cochrane collaboration globally for really bringing in a paradigm shift in the way we think, the way we look at evidence, the way we take decisions on evidence. You made it a norm. So I like this hall to give a very big hand, applause to Cochrane collaboration and all of you who have been part of it. It's so amazing. Before the era of computer, there was a big fat book which NIH produced somewhere around 90s, which tried to do this for the first time for newborn health. It's so fascinating. I couldn't afford the book, but that's how it started. And then, of course, the movement grew. This very notion of systematic reviews has been germane to the achievements, particularly in child and maternal mortality, but I'm sure in other spheres as well. I'm not very familiar. So a big hand to global Cochrane community and the Indian Cochrane community. You have done great service to humanity. Thank you. Thank you, and let us know how we can strengthen.
Thank you, sir.
Oops, truly, every which way, and Dr. Bahal indicated to us how a strong foundation has now been built. This should be part and parcel of training of a lot of postgraduate. Talk about that, how to increase that. And a stellar work done by my very distinguished colleague, Dr. Meenu Singh, in this regard is absolutely noteworthy. And Meenu, you have a lot of work to be taken forward beyond what you have done so very well. Quickly, the challenges. Okay, before the challenges, to complete the story of what India, because it's India's story, to just put on record, some things were mentioned by Dr. Bahal. The Indian paradigm of newborn health, moving from sophisticated incubator-driven, NICU-driven thinking of newborn health started to change somewhere around mid-80s. We had a very path-breaking report called Minimum Perinatal Care for India in 1983-84. So my teachers had already done a few very good things by that time. So among other things that have been mentioned, India in a significant way would like Indian, I would say public health, newborn health fraternity has contributed the following. Home-based newborn care has been mentioned. The roots of facility-based newborn care go back to mid-80s when Dr. Jayam created a newborn unit in a district hospital near Vellore. She also demonstrated the use of Paladay and the spoon feeding at that time. I want us to pay a tribute to her. I like to also mention that the Indian IMCI became IMNCI because Indian fraternity created the evidence, or looked at the evidence and helped it to embrace, and now it's a global paradigm. For neonatal resuscitation program, India was a big force multiplier. For Kangaroo mother care, hard work of Dr. Shashivani starting in early 90s has been stellar force multiplier because it helped scale up in the biggest country. QI movement in newborn care from Dr. Ashok Deorari, my very dear colleague, has been one of those things which changed the thinking. So we're very proud that this happened, and all the way it was being helped by evidence synthesis systematically, that we learned to do better and better. A game changer in the policy was the Janani Suraksha Yojana, which incentivized in around 2005 institutional deliveries, having this conditional cash transfer and matching it with supplies made a huge difference of moving from mid-40s institutional delivery rate to almost perfect, or 90%, close to 90% institutional deliveries, which improved maternal health as well as newborn health. I wish to point out to you that as we move forward, very rightly the mention has been made about a few challenges. I would not go into all of them, but I think the point is that we will have to be able to go further in reduction of newborn babies. We need to focus on smaller babies, we need to focus on some of the categories of babies that have been mentioned, but we have to be also able to address the birth defects, which means surgical care. And so surgical, neonatal surgery, or early infant surgery have to be a part and parcel for us to push neonatal mortality to a single digit and beyond that. In our journey toward 2047, our goal is to have an infant mortality rate of 3. 2047, IMR 3. $30 trillion economy, life expectancy 85 plus, and IMR 3, which would mean that from now onward, which we've done partly, we have to be address the difficult conditions such as the surgeries. And here I'm happy to tell you that through the world's largest health assurance scheme, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, a huge population of India, huge number of households of India have access to cashless care, including all the critical neonatal surgical conditions through a network of not only government hospital but also private hospital, cashless to the tune of $500,000 rupees. And that provides us a pathway for taking care of surgical conditions that, in fact, it is assured. And not to go into the details, but close to 1 billion people, close to 900 million to 1 billion people are covered overall through the union government scheme, topped up by the state governments who have added additional population into the ambit of Ayushman PMJ, as well as employees' social insurance system that provides coverage. So if you put it all together, 900 million, close to 900 people, or perhaps even more, are actually assured for services. We must harness that. And that's cashless and so on. I like to mention the following challenges that worry me. One, and they're not in a particular order at the end of the seminar, but I want to say I'm very concerned that the nutritional outcomes of our babies being discharged from critical care units, SNCUs, or otherwise are not optimum. Huge number of babies coming out of the SNCUs, even at 4 months, are undernourished. Specifically for preterm babies, in a study, 52% babies don't have good nutrition. Can we improve nutrition within that sickness condition, which may be difficult, but can we improve systematically over a period of time? Because this group is the major group that's contributing to the stunting and wasting in the first year and beyond. I need focus on this. We have not really focused on optimizing nutrition because, and rightly so, all of us were concerned about survival. Survival, we are doing well. Nutritional outcomes, no. And the second part is to improve outcomes, neurological outcomes, and intact survival has been our concern, and improving or reducing the rate of retinopathy or prematurity, cerebral palsy. But today we should start thinking about, and emanating from the evidence that we have, the ways and means of not even losing a single IQ point for our future generation. That's our aspiration. Not just absence of cerebral palsy or intraventricular hemorrhage, no. We need to go beyond this and make sure that the best possible cognitive and sensory outcomes and language outcomes, not just gross motor outcomes, are available to our children, our babies, and these are obviously the high-risk babies that are most vulnerable to this. How can we do that? Kindly guide us in this regard. Neonatal screening would be an area. Give us the evidence, get us how it is to be done, is an important part. Optimum feeding of low birth weight babies in communities coupled with kangaroo mother care is suboptimal in terms of coverage and quality. We need to improve that. Dr. Meenu mentioned how technology can help improving the home-based newborn care, topped by technology. We should be very mindful of antimicrobial resistance because neonatal units are a very major contributor in terms of attributable fraction to the antimicrobial resistance. Babies need antibiotics, but then we have to be very careful. I want us to be mindful of this. I would like us to think about how health and wellness centers, 174,000 health and wellness centers can be mainstreamed for better neonatal care, because we have a team of a trained and fully qualified graduate nurse with special training. I do not see optimum use for newborn babies, for children, being made of this wonderful primary healthcare system that we have created. We would like to see that being used systematically. I like two specific requests for Cochrane review. I'd like to know on the more recent information about the contribution of low birth weight babies, specifically premature and SGA babies, toward stunting in more recent times and wasting in the Indian context. What is this quantum? How much have it changed from the previous one? It is so critical because we would like the focus on the care of the mother, care of the adolescent girl, preconceptional care, to be mainstreamed into the thinking that leads us to address the challenge of undernutrition. That's my one specific request which I would like to make. I compliment you for this work that you all have done. We are proud of where we are. And India's story of neonatal mortality reduction is higher gains than the overall global journey. And it goes to the credit of the people of India, the health system of India, the leadership of India, and the partners and academia. Thank you very much.
Thank you very much, sir, for your insights of bringing the past and the newer developments in neonatal health together. So thank you all distinguished speakers, panelists, and participants for making this a success. We request the chair and co-chair to please hand over a memento for appreciation of the panelists. So it will take 2 minutes, sir. Please come on stage, Yamini and Perlin.
क्या हुआ?
फोटो नहीं हुआ, फोटो लिया था सबका एक
me set up a little bit? Charging, I think I'll give you the charger if you can just... Is there a plug point here? Because I don't want it to die, and I'll just set it up. Oops.
test results for tuberculosis or infant HIV can take up to 100.
Yeah, actually, it's good to keep it. Please settle down. We'll get started with the keynote address from Tisha Boatman.
In some settings, test results for tuberculosis or infant HIV can take up to 100.
Okay. That was not planned. It's interesting, he's changing the panels. Yeah. He's done? Okay.
In some settings, test results for tuberculosis or infant HIV can take up to 180 days, which is sadly too late. Only one mammography system is available for 460,000 women in this archipelago of 17,000 islands. Today, one radiologist is serving roughly 500,000 Tanzanians, whereas the world benchmark is one radiologist for 50,000 people. There is a demand for comprehensive healthcare services in the rapidly expanding suburbs of India. Patients often travel for more than 100 kilometers to receive treatment for serious conditions like cancers and strokes. It is our privilege and obligation to provide access to healthcare, no matter where people live. Our solutions are reaching patients in the remotest areas of the world. In pilot locations of Ghana and Côte d'Ivoire, average test results time has been reduced to less than 5 days.
UNICEF and our implementing partners are proud of the progress we have made in diagnostic optimization in the pilot settings. The reduction in turnaround time for test results is really game-changing and will help save lives.
We are organizing customized radiology training programs across 24 sites in Tanzania.
Our staff is learning how to utilize these advanced medical systems, not only to improve patient outcomes, but also to enhance the overall productivity of the hospital.
We are supporting the Sri Lanka breast cancer screening program to screen 30,000 women from remote areas of Indonesia annually.
Jika bukan karena program Selangka ini, saya tidak tahu berapa waktu lama lagi yang dibutuhkan untuk menemukan benjolan di dada saya. Rasanya seperti menemukan kesempatan kedua dalam hidup.
We installed basic imaging solutions on an isolated island in Vietnam, so patients no longer need to travel by sea to reach the mainland.
Hồi trước giờ ở huyện này chưa có cái máy CT, trước mắt là thấy nó đỡ một cái tiền là chi phí đi về trong kia, rồi thứ hai là nó đỡ cái thời gian mình đi trong kia khám bệnh.
We pioneer breakthroughs in healthcare for everyone, everywhere, sustainably.
Healthcare is a human right. Good morning, everyone. The video you just saw showcased our innovative technologies to help build resilient healthcare systems, thereby increasing access to care. I'm Tisha Boatman. I head up external affairs and government affairs globally, as well as healthcare access for Siemens Healthineers. I'd like to thank very much the organizers of this wonderful summit, including the World Health Assembly, the World Health Summit, and NIMS. Today I will share a little bit of a view of the perspective of Siemens Healthineers on how we see building healthcare access around the world. In a recent report, the World Health Organization and the World Bank have published that over half the world's population still lacks access to healthcare. Unfortunately, we are a far way off from the UN Sustainable Development Goal number 3, recognizing that all humans deserve access to universal health coverage and quality health care. This report from the WHO serves as a wake-up call to the global community, a much-needed focus in order to achieve that health care for all. Lack of access to essential services is a result of multiple challenges when we look at the topic. Some of this comes from lack of infrastructure. You see an example here from the Philippines, where unfortunately 47% of Filipinos have to travel over 100 kilometers to access radiotherapy services if they are diagnosed with cancer. Just to give an example from the home country of Siemens Healthineers, in a place like Germany, there are approximately 7 radiotherapy units per million population, a stark difference from most of the rest of the world. Lack of knowledge and lack of skilled manpower can also be a major topic in healthcare. This can include technicians, nurses, community health workers, and also specialized doctors like radiologists and cardiologists. In the video, we showed an example of Tanzania. You saw it there. Some of the numbers are also here on the slide. Unfortunately, for Tanzania, there's a significant lack of radiologists, meaning that diagnostic is often not available to patients who need it most. And again, comparing to Germany, just to give a reference point of one of the OECD countries, in a place like Germany, you generally have 12 radiologists per 100,000 population, where it's only 0.2 in a place like Tanzania. There are also barriers with regards to financial hardship, as we all know. Many places, and India is unfortunately the country in the world which has the highest out-of-pocket expenses for healthcare, with 50% of costs often not covered, and sometimes households having to go into poverty to cover for care. These are just a number of the challenges, and we'll also talk about some solutions and opportunities. One of the things I'd like to focus a little bit on is NCDs, or non-communicable diseases. Unfortunately, non-communicable diseases disproportionately impact low-resource types of countries, and with 77% of the deaths from NCDs coming from low and middle-income countries. This is, of course, a significant drain on communities and on resources, not to mention the health system. At Siemens Healthineers, we want to play a significant difference in health, and one of our main topics is women's health. There's significant challenges in women's health in particular. Over 50% of the world population, as we know, is women, but unfortunately, less than 1% of healthcare studies and financing goes to women's conditions in particular. And women, as an example, a simple example of how this results, is women have a 70% higher chance of dying of a cardiac event than men, simply because many physicians around the world are still not trained to recognize the unique symptoms in women. It's one of many different challenges that women face, which we'll talk a little bit more about. This is not the right, yeah. Hang on just a second. We need to, yep. Where is it? Can you help me find it real quick? It's here, I think. This one? Sorry, we've had a little mix-up with presentations. Yeah, okay. That previous slide was a picture of me. I'll just explain what that was real quick since you saw it. I'm a breast cancer survivor, and I went through breast cancer concurrent with COVID. In April of 2020, I found a lump in my own breast, and I was living in Denmark at the time in a very well-funded public health system. That experience is part of what convinced me to focus on health access in my business here at Siemens Healthineers. Now we're back into the correct topic, so I'll continue with the presentation that we wanted to cover more today. Siemens Healthineers is a company that's been around for many, many years, 120 years now, and I won't go through all of the statistics on the slide, but I do want to highlight a couple of things. I mean, first of all, we have 72,000 employees around the world in 70 countries where we are located and present ourselves, including, of course, India, and I'll talk about that a little bit more in a minute. We also serve nearly every country in the world through distribution partners and seek to bring access to everyone everywhere. We are heavily invested in R&D, particularly when it comes to developing AI and digital solutions, but really all kinds of healthcare solutions, again, with a strong focus on NCDs, but not only on NCDs. And we do focus on improving patient impact in particularly. So on the right side of the slide, you see this topic of 1.25 billion patient touch points. We have a focus on increasing our impact on patients globally. We target to have 3.3 billion patient touch points per year, starting in 2030. They're in 1.25 billion of those in low and middle income countries. Just to give a reference of where we are today we're nearly at 1 billion patient impacts per year in low and middle income countries, but we want to grow that at a very high rate in the coming years. As I mentioned, digitalization and AI are a big focus of what we do. We do look very closely at a topic that I heard a little bit referenced in the previous panel, and that is the topic of having diverse data and unbiased data. And as an example from our perspective, we build our algorithms on over 2 billion data sets from around the world. When it comes to AI, we have many, many solutions in AI. I just want to highlight one example. It's an example called Deep Resolve. Deep Resolve is an MRI brain algorithm, and it essentially makes the pictures from the MRI much easier to understand, much clearer and sharper, and it significantly speeds up the exam. So if you've ever had an MRI, I've had quite a few as a breast cancer patient. When I first started getting MRIs for the breast, only about 5 years ago, I would spend 65 minutes in the MRI machine getting my exam. These days, that's been reduced substantially, and most of my exams are only 20 to 25 minutes. In brain in particular, these can be very long and complex exams. You imagine patients with brain injuries, it's very difficult. So we've shortened substantially the amount of time required for a brain MR and expanded that technology's availability to many more patients around the world using Deep Resolve AI as an example. I started talking about this before, but I really want to pause here for a second and focus on sustainability. At Siemens Healthineers, sustainability drives everything we do. And this slide summarizes our commitment in sustainability. We really see it across 3 pillars. One of those is healthcare access, and I'm going to spend a little bit of time there. An additional one is resource preservation, or preserving the planet's resources. We are committed to achieving net zero in our company across our scope 1, 2, and 3 by 2050, as well as driving decarbonization deep into our value chain. We are also promoting circularity with eco-designed and refurbished types of products. Our final pillar is around diversity and engagement. We seek to increase women in leadership roles in our own company, setting an example for other industry organizations around the world, as well as leverage the strength of our Healthineers around the world. And all of this is underlined with strong employee-led initiatives, as well as partnerships. And by partnerships, I mean all kinds of multi-sectoral partnerships. I'm actually going to give a few examples of those because they're very important to how we achieve health outcomes and healthcare access. With healthcare access, though, let me just stay here for a second. This is the first pillar and the most important pillar that we see in our responsibility as one of the largest medtech companies in the world. And this is really to bring breakthroughs to everyone everywhere. We underline our commitment with affordable access solutions across diagnosis, comprehensive care, as well as skilled workforce. In many, many places, the biggest impact one can have, a company like ours can have, on improving health outcomes and extending life is increasing the availability of early diagnostics. Diseases, and particularly non-communicable diseases, the reason death rates can be very high, the reason they can be economically very challenging and financially difficult to treat, even though we have solutions today, is because disease is caught too late. It's caught at stage 3 and stage 4. We really put a lot of our focus and effort, and I will show you specific examples on increasing access to diagnostic and early diagnostic for critical non-communicable diseases, meaning catching those diseases at stage 0 or stage 1, ideally. In education and training, again, we'll come back to that, but I do want to emphasize here that we have an external commitment to provide 6 million hours worth of education and training per year by 2030. Today, we are at about 4.5 million education hours per year that we provide globally. Now, I said I would mention a bit about partnerships, and I'm not going to go through all of these partnerships. These are some of our headline partnerships that we have around the world, but I'll mention 2 of them. The first is the one in the middle with the Global Fund. We have recently launched this program in the Philippines. It focuses on the use of AI to speed up and improve the quality of diagnosis for TB, for tuberculosis, which is the #1 world's killer in communicable diseases. Unfortunately, TB declined slightly during COVID, primarily because the world was focused on another disease and wasn't looking for TB as heavily, but TB is again on the rise, and we are unfortunately far from the goal of eliminating TB by 2030. We are partnered with the Global Fund to provide AI and, importantly, to provide the effective implementation of AI to improve the early diagnostic of TB. A couple of years ago, the WHO changed their recommendation to say that TB is best screened with AI-enabled X-ray, and then diagnostic being done with a sputum test or a lab test. But the faster and the more economically efficient way to screen is with low-dose X-ray and AI-enabled. In this case, we use a company called Cure AI, which is also here at this conference. I'll be on a panel with them later today around digitalization and AI, and this is a great example of a partnership because Siemens Healthineers works with the Global Fund, the world's largest private funder of TB programs, and Cure, an Indian AI company, to provide this solution, and in this example, in the Philippines. The other one I briefly want to highlight is with CCAN. You see this logo on the right there. CCAN stands for City Cancer Challenge. They are a non-governmental organization based in Geneva. They focus on providing, helping cities across multi-stakeholders look at their current situation for diagnosing and treating cancer and improving that. We fund several programs through CCAN. One of those is focused on breast cancer, for instance, where we've reduced the time between diagnostic and starting therapy in the city of Cali, Colombia, from over 60 days to approximately 5 days. We're rolling out that breast cancer program with CCAN to other cities around the world. We also do a women's leadership program, particularly around gender bias for women leaders in oncology care with CCAN. And we work with them on digitalization and capacity building, education and training. So it's a very comprehensive partnership we have with City Cancer Challenge, and a great example of where Siemens Healthineers believes that we can make a significant impact, but also with partners around the world. I want to talk a little bit about specific solutions to some of the challenges of accessing healthcare. And I'm going to touch on solutions in each of these areas here, so I won't read them to you now. But let's first start with talking about an example around technology in particular. So MRI is, and I mentioned it before, it's incredibly important for certain types of diseases, both to diagnose and to monitor whether treatment is working, monitor patients as they go through the patient pathway. This is particularly true for brain disease. I mentioned the Deep Resolve AI as an example, but it's also true for types of musculoskeletal diseases. And these are the types of diseases that very often go undiagnosed for a period of time because the right technology is not available to diagnose them. We have invested in helium-free MRI. MRI requires helium to produce the images. Helium is a scarce resource around the world. It's also a very difficult resource to refill. So when an MRI system is installed at a hospital or a clinic, it will have helium in it, but then you need to, for traditional MRI, you need to replace that as it depletes with use over time. We've developed a near helium-free MRI system, which significantly improves the ability to have this technology available. It's also much lower field, meaning the system is lighter and it can go into facilities that previously would not have been able to have MRI. With that, it's created tremendous new access points for clinicians around the world to be able to provide this significant technology to their patients. And in our case, we are aware of 27 low and middle income countries that now have MRI access that previously did not before. So most of the installations we're doing of this equipment are first-time users of MRI because they previously couldn't have this particular technology in their geography. So there's been a huge breakthrough there, really bringing this care to new types of patients. I want to briefly touch on geography. That's not a picture we see too much in India, right? It's been over 40 degrees the last couple of days here in Delhi. But you do have, in the northern part of India, in the Himalayas, as you know, icy road conditions, and certainly geography and access, whether it be islands, whether it be lack of road network, jungles, all of the different conditions that cause a lack of access are relevant also here in India. I want to briefly talk about a stroke example in Norway. This is one of the examples. There's a distance by road between the two cities you see on the map here, Tromsø and Finnsnes, of about 4 hours travel. Now, we think of Norway, it's a publicly funded healthcare system. I remember I said a minute ago I had cancer when I was living in Denmark. I lived in the Nordic countries for 8 years. Norway is one of the best healthcare systems in the world, well-financed, publicly funded system. Even in Norway, though, over half of patients who have a stroke don't reach the hospital in time, in the so-called golden hour, which is necessary to save brain and save lives. In Norway, often that has to do with road conditions and distances. The weather is often where helicopters cannot fly. So yes, of course, they have this technology to fly patients, but the weather usually makes this a problem, and that is why half the patients don't reach hospital in time. In this case, a telemedicine, telehealth solution is used to enable the clinicians in Finnsnes, where they have a CT, to diagnose and start the thrombectomy treatment without the patient having to be moved to Tromsø. So simply by putting in the right communication technology, the physicians in one site can be enabled to support patients in another. And it makes a huge difference. We've done this in many places in the world. But I like to use the Norway example because there is sort of an assumption that a place like Norway can't possibly have healthcare access challenges, but certainly they do. Unfortunately, these types of challenges exist everywhere in the world. Good, I want to talk a little bit more about gender, and here comes that slide you saw before where I started talking about gender. It is a topic we spend a lot of time on in Siemens Healthineers because we do believe that closing the gender healthcare gap is part of our obligation to public health. The previous panel, if you were in the room here, was talking a lot about neonatal mortality, and certainly there's been massive improvements around that around the world. I'm going to focus a little bit more on the NCD side, on the cancer side, but we could go into many areas, as I've mentioned, where unfortunately investment in research in women's health, training and education programs, and the general focus on women's health are not what it should be around the world. Good. Breast cancer for us is a big focus. Cancer in general is a big focus, but breast cancer is one of those areas where there's been tremendous innovation in high-income countries. If you look at the last 30 years, we've extended life for women diagnosed with breast cancer substantially. It used to be somewhere in the 60% to 70% of women who had breast cancer in high-income countries would unfortunately pass away from that cancer within 5 years. Now, the 5-year survival rates in high-income countries are as high as 98%. Why is that? What has been done in high-income countries? There's been a ton of different innovations, but the most important one is early diagnostic. In breast cancer, and remember, I'm a patient who found my own cancer at stage 2. In breast cancer, early diagnostics makes all the difference. And unfortunately, women in low middle income countries have a 78% chance of dying of breast cancer because cancers are caught too late. So a lot of what we invest our effort in is helping the over half the world's female population that doesn't have access to breast cancer diagnostic obtain that access. This is one example here in Egypt. Egypt, we have to applaud, the country has done a really great work. They have something called the Women's Health Initiative in Egypt, where it's part of their Egypt Vision 2030, and they have this slogan where saying that the Egyptian woman is the health of Egypt. As we know, women are very often the center of a family and the center of a community. But too often women take care of everybody else's health in the family before they take care of their own. In the case of Egypt, they're really trying to change this narrative. And starting with breast cancer, but addressing all aspects of women's health. In this case, we have been training 300 mammography technicians to read cancer images to position patients correctly for mammography screening as well as read those images. And this supports Egypt's effort to screen their 38 million women for breast cancer. We also provide our mammography systems in 90 mobile trucks that now go around the country, 90 different new mobile van solutions to offer screening camps for women in their communities, reducing the requirement for them to travel to central main cities and central hospitals. Breast cancer is a global topic. I'm going to take you now 6,000 miles to the east. You saw this in the video if you were in the room already. Indonesia has a significant challenge with breast cancer. Here, we work with Siloam Hospital. It's a private provider where they're trying to screen women in the Selaganka program. The woman patient you saw in the video is part of that program. They're providing 20,000 free scans a year to the women in their community. They are not reimbursed by the government for the diagnostic, but they do receive government reimbursement for the therapy, so for breast cancer intervention, be it chemotherapy, radiation therapy, whatever is required. And that is the true case in many universal health coverage systems around the world where the diagnostic is not covered, but the intervention is. And this is one of those topics that we are working with governments seeking to try to improve that so that early diagnosis is part of government health care. Finally, I'll touch on skilled manpower. I mentioned before that education and growing capacity in health systems is a big focus for us. There is going to be a global shortfall of 11 million healthcare workers by 2030, and this ranges from nurses, doctors, community health workers, all of those key roles essential to make a health system function very well. Unfortunately, with the growing disease burden, this problem is getting worse, and the good news is people are living longer and longer, but the strain on the health system is only growing year by year. We do a number of programs around the world. We think it's very important also often with partners to upskill staff. This one in Egypt, again, happens to be in Egypt because the government's investing very heavily, but this is with Cairo University as well as Siemens Healthineers. We have a training academy that has trained over 2,300 physicians so far. It's been in place for less than 2 years now on various skills and technologies necessary. And these people come from 13 different African countries in North Africa and Central Africa. This is actually in our offices. We host an academy in our offices, and some of the clinical courses are provided, like I said, with Cairo University in the hospital. So great example of partnering in order to achieve upskilling and covering much more in this case than the country of Egypt. Good, so I want to shift briefly to Siemens Healthineers in India. I'm going to touch on this just very briefly, a few things, again, not going through every bit of information on this slide, but we have been present in India for over 90 years. We have manufacturing experience of over 6 decades in India in 2 locations where we manufacture our imaging products as well as diagnostics products. And that's both India, but also for the global market in the case of some products. We have 7,000 passionate healthineers in India. It's one of our largest country locations around the world. And multiple times we've been certified as a great place to work. We do a lot of R&D in India. You know, a lot of times when people think of Siemens Healthineers, they'll say, well, German engineering. And yes, there's a piece of German engineering in it, but there's actually a very large piece when it comes to software of Indian engineering. And Indian software engineers make up over half of our global software force, most of them out of Bangalore. We also run here from India. We run our software programs for around the world. So our other tech centers are managed out of our location here in India. So lastly, a couple of important examples. You saw a lot of examples, and I promised I would bring you back to examples here in India. We have been able to address accessibility challenges, and this example here you see is addressing one of the areas of India in Assam with one of the highest cancer incidents in the country. There's about 30,000 cases a year in Assam. And many, many patients had to travel over 1,000 kilometers to Calcutta, which, as you know, can be a 24-hour train ride if somebody needs to go for cancer treatment. This program in particular is with the Assam Cancer Foundation and Tata Trust, and it's part of the National Health Mission. It's a 3-tiered solution where there's a community outreach program, there's some small local centers where people can get diagnosis and some of the basic care, and there's a hub and spoke model connecting 3 larger tertiary centers for those that need more advanced care. This is one of the examples where we've been focused really on providing diagnostics, on that early diagnostic in the community, and as well as optimizing the patient pathway. Second example is with RT scans. RT scans is serving 8,000 patients daily at a very affordable cost for both imaging and lab. Again, very focused on early diagnostic, because if you want to make a significant difference in NCDs, if you really want to solve that challenge, it is about catching the disease early. We have the technology today globally, generally, to treat many, many NCDs in an effective way, but only when we catch it at the earliest stages, or primarily when we catch it at the earliest stages. In this case, RT Scans is a customer we work with very closely. They're providing excellent care across their many centers, and they also have a digitalized patient journey, which helps them optimize their ability to deliver care even in remote locations. And finally, breast cancer. I would be remiss if not stopping, if not coming back to the topic, because it is so important to me personally, but also something that we do a lot of in Siemens Healthineers, because we see a real opportunity there to extend life around the world. This is a program with Project HEAL, which is run with the Rotary Club and KMCH. It's in Tamil Nadu. And this is a mobile clinic which aims to do 200 free screening camps per year around the state of Tamil Nadu, and has been in place now for a period of time, has been up and running. We're continuing to augment this program. So good. The solutions that I illustrated here do not stand in isolation. They were a few examples. They're embedded in our larger framework, which starts with sustainability, as I talked about it. One of our major pillars of our approach in Siemens Healthineers is expanding healthcare access. It is a foundation of everything we do. Those efforts are built upon, of course, a long history of innovation and technology, but they also look at the different aspects of the value chain to really enable healthcare and expand the availability of care across different types of health systems. Affordability, availability, and innovation have an interplay role, and we see ourselves as a company at the center of that we can provide that also with partners, as I highlighted. I want to finish where I started, right? I said healthcare is a human right. That's the first thing I said after the video, if you weren't in the room. And this is really what we firmly stand behind. As you all know, it is an incredibly turbulent world that we live in today, with constant geopolitical challenge, solutions available, but unfortunately not accessible to far too many people, and a constant situation of change. For us, we stand by our values. We stand by our purpose of pioneering breakthroughs in healthcare for everyone, everywhere, sustainably. It's the core of what we do every day. Thank you very much for listening, for your attention, and for your focus on healthcare as you're here at this event today. I'm going to now be joined on stage by one of my colleagues, and a few others will have a brief discussion on a few of these topics. So thank you. Maybe we can take the slides down. Perfect. Great. We've got microphones up here already.
Thank you. And Tisha, that was really very inspiring. The fact that, you know, the impact which Siemens has done and, you know, how you've driven that over a period of time. I think a lot of that is very relevant to India as we look at it. You know, we are now the largest country in the world from a population point of view. And, you know, healthcare is one of those unique things. You know, it follows something which is called Taylor's Law. And I don't know how many of you know what's Taylor's Law. It's always in a perpetual crisis, right? So if you picked up a newspaper 50 years ago, you'd say there's a crisis. If you picked up a newspaper in 2020, you don't need to tell me what the crisis is. And if you go to pick up a newspaper even 10 years later, it'll again be. In a lot of ways, by the time we get the answers, the questions change, right? We never anticipated COVID. So it could be, you could look at it as a perpetual crisis, or you could look at it as a perpetual opportunity. I remember being in one of these debates in the US a couple of years ago, and where the debate got on in the end to say which is the best healthcare system in the world. Is it the US? Is it the UK? Is it, you know, Singapore? And what was very strange, people from those healthcare systems said ours is not great, right? So we had someone from the NHS, and I remember he said that if we were to look at a healthcare system today, the NHS will not even make it to the short list. So it was a creation of something which happened after World War II. But the whole problem is there is no great system in the world, right? If you look on the axis of accessibility, affordability, every system has lacunae. I spent time in the US in one of the large academic medical centers. I felt that the clinical care was excellent, but did it make financial sense? May not. You know, because, you know, someone like Singapore spending 5% of GDP has better outcomes than the US. I think the greatest thing, and we said, you know, commission to, you know, access. And I think in India, we could really say this is 3 types of access. One is the geographical access. And, you know, you spoke about Indonesia where it's even worse. But 70 to 80% of our infrastructure is just in 20 to 25 cities. So there's a huge concentration, both in terms of infrastructure and doctors. And it's not changing, you know. I'm sure if you come to Delhi, every time you find it gets bigger, right? Because we're getting much, much more urbanized. Though as a country, we're going to be there in 20 years where China is today in terms of urbanization. Second, I think what the government of India has done from that point is actually give a financial access. So 50% of India's population now has some sort of a financial access which is sponsored by the government. But I think in India, we look at it separately. We play to our strengths, you know, and you know, Hari knows we had the chairman of Siemens come over, and he said one of our strengths is IT. So ultimately, are we looking at a technological access to care? So as you look at this paradigm, how do you think this whole access to care is going to change in the next couple of years?
I mean, certainly technology has a role to play. You hinted on India's strength in digitalization and IT, and I think that's absolutely the truth. However, we really have to look at implementation. And I mentioned the topic using the Cure AI software, and you know, what is Siemens Healthineers doing there? Well, we're really focused on making sure that the users know how to use the AI and they're using it effectively to actually have better outcomes, right? The Global Fund, as an example, has been providing AI or providing funding for AI for some time now for TB. But in some countries, they don't actually see an improvement in outcomes, in more patients screened and earlier diagnosis occurring. So our role there is really around implementation. So I think technology is important, digitalization is important, but it has to be effectively implemented. And I think even more important than technology is the culture and the mindset, right? As you started off by saying, you know, we could look at every 10 years or every decade and we could say, you know, this is the biggest problem or this is the biggest opportunity. But the question is there a real mindset to drive change, to make a difference, to tackle challenges, to come together in a multi-sectoral way and to achieve those? You begin to see that. And I really have to, you know, give a lot of credit to the Indian government here. You know, Ashram Bharat is the best implementation I have seen of universal health coverage, where they're really tackling a significant challenge in the terms of the number of people, the situation of access, the situation of affordability. India's made tremendous progress, and I think this conference is an example of the commitment to continue to improve in that direction.
Great. I think, as we go ahead, Hari, one of the things, and we were just talking about it, is not only the potential to serve India, but, actually. So when we talk about, medical tourism, and now it's called medical value travel, over a period of time, people talk about, the arbitrages in terms of, it costs 1/5. But there's also a skill arbitrage, right? Being a clinician, I know the Indian clinicians probably done 10 times or 20 times the cases. So the accessibility to care in India is still limited by the affordability. How do you see this changing?
Yeah, Rana, you're right. Actually, India is the destination for, let's say, healing from India to the world. That's the program of the government as well. Affordability is one of the most fundamental topic for access in India. And as a leader in innovation, some of the things what we do is, how do we make some of the technologies really accessible and affordable? And Tisha talked about it in the earlier presentation that MR is a crucial, complex piece of technology, which is crucial in early detection and also follow through. So getting this technology geographically to many other locations and also in a resource constrained setting, it's our responsibility to innovate. And some of our newer innovation, and these are made in India, is an example that we're very proud of, where we clearly challenge the access challenge for getting MRI. So affordability, clearly. And second thing is geographical. How do we get treatment closer to patients? And that's something where some of the digital tools and remote scanning makes a big difference. All this, while you can debate what Tisha mentioned in a slide, it takes 11 weeks to get an MRI appointment. Maybe some parts of the country will get it faster, but some places you don't. And there, remote scanning, making technologies like CT, MR accessible makes a difference. Yeah, and I think the third dimension is, while we can get technology and capital also, getting skilled people remains a challenge. And this is not something which we can do by ourselves. We work with leading players, government, and academia to continuously train and skill beyond application, including general medical assistant, nursing. So it's a joint responsibility, I would say. And of course, we work on technologies which brings innovation at an affordable cost.
No, I think that's important. And I think one of the biggest changes, we've seen in the last 10 years in India is a lot of specialities have moved outside. There's been an unbundling of the hospital space. When I worked with Apollo in '97, our logo was, we are a one-stop shop for everything. But say something like eye care has just moved out, right? You don't do it in a hospital. Because I think one of the things is technology has made outcomes much more predictable. So you needed a clinician who probably had 20 years experience. Today, I think that clinician with 3 years experience has the same outcomes. So I think that's beginning to happen. That also, and you can see, is now the tier 2, tier 3 cities and beyond. People are willing to go there because you're getting the same outcomes. One of the things I wanted to ask you, Tisha, we pretty much have in India a pre-COVID and a post-COVID. Things have really changed, in terms of the utilization, the capital. And a lot of people also credit this, that the smaller cities, in COVID, what happened, mobility stopped, right? So ideally, someone in a city like Agra, if he had a problem, he'll take the highway and come to Delhi, right? He couldn't do that. So he went to his local hospital, and he said, it's not that bad. The owner of that hospital say, if I upgrade myself, I can get this guy. So we're seeing a big change in that. So how do you feel that, post-COVID, these healthcare systems are getting more resilient based on technology and access?
Yeah, I mean, COVID taught us a lot of things, right? And I hope some of these, lessons really last. I mean, certainly remote technology can enable hospitals in less attractive areas or in smaller areas. But there are other topics as well. I mean, a lot of physicians like yourself, they want to work at the top of their license, right? They want to have access to some of the more advanced technologies. They want to ultimately make a difference in patients' lives. And if they feel they can be enabled to do that in the communities where they were trained and in the communities where their families live, they may choose to stay there, right? And this is a topic we really see a lot in Africa in particular. Unfortunately, you have a high number of physicians who are trained in Africa who, if they're English speaking, not unlike India, not unlike Philippines, end up in the NHS, right? And end up in other systems. And part of the reason they choose to leave, sure, there's some aspects of exploring the world, but a lot of it has to do with being able to work at the top of their license, right? So we do try to enable geographies around the world to have technology that allows clinicians to solve problems locally and not have to send their patients away for the most difficult pieces. I think the other thing that COVID taught us was that major health crisis can happen to anyone. COVID didn't care if you had insurance, high quality private insurance. COVID disease could care less what the border was or where you worked or what socioeconomic status you were from. COVID showed us that healthcare access is critical for every single human being. And I think that's one of the most important lessons. Governments, private providers, and just humans as people, we pay a lot more attention now to where our healthcare comes from, how far away it is, how accessible it is, and how my neighbor's healthcare might actually impact me. If they don't have the same access. So I hope that part of what comes out of COVID is a lesson in equalizing and raising the standard of care for humanity. That's one of the pieces that is a lasting lesson that certainly we've taken very much to heart in Siemens Healthineers.
No, exactly, and I think you speak from personal experience, right? Having a lesion in your breast and at the same time, having COVID, the whole access, because this is something we didn't know. And if you look at traditionally, the way hospitals are built, they're built for trauma, right? If there's an explosion, you get people, you put them all together, you treat them. And suddenly you get COVID, where, you need that 6 feet apart, right? Because there's a space which needs to be sacrosanct. So I think the way we design hospitals, the way we design public spaces is also going to change, because we never thought of a pandemic. But that's, we never thought of putting, you'll go through an ICU and see all the monitors are actually outside because you cannot access it. So, Hari, I think one of the things we've done in India, which we were talking about, resilience, and I was recently in Indonesia in one of the hospitals you mentioned. I think the biggest problem there is still the supply side constraint, right? You cannot, because you just don't have enough doctors, you don't have enough nurses. But I think in our last 10 years, we've really doubled the number of doctors, nurses, super specialists. So I think one area we've become much more resilient, right? I was recently, there was a hospital in Haldwani, and he said, I don't have a problem, I can even get a DM. He wouldn't have been saying that even 5 years ago. So things have changed. What are the other building blocks you think which will make our healthcare more resilient?
I think building, like you rightly said, the skill gap, while there is still lots to be done. In the last decade or so, the capacity side, what is called supply in terms of clinician nursing, is kind of doubled, education as well as. But in terms of resilience, I guess, like you said, the whole focus of moving to preventative healthcare, right? Screening, early detection makes it better to manage. And that's a journey which has to happen. And for that, you need advanced imaging technologies and digitalization and AI. These are founding blocks. And I guess that is the crucial step that has to happen. So we have built capacity for treatment and curative healthcare, but for early detection and diagnosis. And this is, again, like I said, one is looking at through the lens of Siemens, what we do globally. But if you look at it, COVID, or even the recent monkeypox, people would have kind of seen it heading the headlines. These are some of the solutions we built locally to to respond very quickly to India. So I think the larger role is on the preventative healthcare, and I think the early screening and diagnosis, and there we have a very important role to play, how we leverage digital and AI to make it really closer to people.
Exactly, and I think you put it, and especially say with breast cancer, early detection is the most important. So, you know, my mother also had breast cancer, and, you know, we obviously went to one of the best specialists. And the first thing he told my mom, see, you know, I won't say getting cancer is good, but getting breast cancer could be the best ones because it's the most treatable. The second, he said, you're lucky because, you know, you've come really early. So these were the two parameters. He said it's not going to change anything because you're sure you'll live the same life and the same quality of life. So I think that becomes, because otherwise, you know, I think what's going to happen is we're going to go into a spiral where we'll get more morbidity and mortality because we're going to detect it later. Today, unfortunately, in India, if you detected it later, you didn't have a financial access. But today, the government's giving it to you, but it may not be the best use, you know, because getting someone in stage 4 and then spending something on which may be futile doesn't make sense. Disha, I think one of the things which, you know, over a period of time is that, you know, the healthcare systems is siloed, you know. This is what the government does, this is what the private sector does, this is what we do, this is what the NGO does. And you know, it exposes a sort of deficits, right? So the government, great, but sometimes execution is a deficit. The NGOs are very good, but they cannot scale up. The private sector, because it works for profit, is sometimes there's a trust deficit. So if you want a robust system, you really need to put all these three together, right? So I trust them, I know I'm going to get value for money, and it's going to be the same across that. So how do you see the partnership ecosystem working out?
I mean, it's a very good point. We talk a lot about public-private partnerships as part of the solution, and they certainly are. But where we've seen real success in partnerships would be something like the City Cancer Challenge model, where they really bring in all stakeholders. So if you're a City Cancer Challenge city, and there is one now in India, one of our colleagues from City Cancer Challenge is here at this conference, you know, they bring in wastewater management, they bring in the agriculture, the food folks, and they look at really cancer as part of a health system strengthening. But one of the advantage things they do, and we try to do in all of our partnerships as well, is start with a set of clear objectives and goals that you're aligned on, and one of those includes how you're going to scale. So you'll hear you know, Peter Sands, who's the head of the Global Fund, say that healthcare suffers from pilotitis, that there's a lot of great single examples out there. And why do they, in the Global Fund, really focus only on 3 diseases, HI, TB, and malaria? They do that because there's plenty to be done there, and Peter doesn't accept pilots. He says, look, we always start from the aspect of scaling. We try to learn from our partners, and Global Fund is one of those partners we try to learn from, which is how do we start from the beginning with a mindset of scaling? So it's not a pilot, it's a proof of concept. We make sure it works, we tweak things, and then we go forward. But agreeing across the system with that from the beginning and having clear skin in the game is important. And it's not only Siemens Healthineers. I really want to put a pitch in here for the industry as a whole. If you look at pharma, if you look at other medtech companies, we are very serious about making an impact on human health. And when we have aligned incentives from the beginning and we understand the model in which we're going to be working on a long-term pathway, people come together and make good solutions. I gave the example of Cure AI. Cure AI is an Indian AI startup. I'm not even going to call it a startup. Cure is a very successful company. And they're a competitor to us in certain parts of the world, right, in certain types of technologies. But we partner with Cure because what they have in TB is outstanding. And we are willing to work also across industry to actually solve health challenges. That's what it's going to take. So I think aligned incentives, a long-term plan from the beginning, these are how you can really bring multi-sectoral, multi-stakeholder groups together and make a real impact.
Exactly, and I think the whole focus is, you know, what gives you the best outcome at the lowest cost, right? I mean, everyone can build everything, but over a period of time, you know, and here I think we'll need to learn from the large tech companies. They do some things, the rest they acquire or they partner. So I think that's Hari, finally, I think one of the things we spoke, and this is whatever we do in India can actually be replicated in the emerging markets, right? Very similar areas, very similar issues, very similar out-of-pocket expenses. So from that point of view, how do you look at getting this whole thing in India together? So while we've been very good, but we've really not, one of the biggest things, and when I was at the Mayo Clinic, I realized the power of an academic medical center, where the delivery of care, research, and the education come together. And that's the reason, you think 90% of the Nobel Prize laureates come from only one country, because they put that whole ecosystem. How can we do that and really then bring Indian healthcare to the forefront?
I think one clear example is, I think we all seem to have forgotten COVID, but the COVID, the way for a large nation like us, how India managed it, and largely in a very, very self-reliant way, is one clear example. And if I want to extend it, I think Tisha mentioned about Cure AI, even MRI, right? We are the world's leader, you can claim, but Indian government is working under the Ministry of Electronics and IT, a project called Sameer, right? And this is a very open innovation, I would say. And we didn't have any hesitation in signing up with them just to explore. And the intent is same what you said. If we can do it here and scale up, why not? And you can argue it's creating competition. But like Tisha said, we didn't have any hesitation in signing up with Sameer to see whether there are any unique things what we can do, which can be scalable and affordable. So there are plenty of examples, like TB is largely India focused, if you see from a global point of view. So, and we created an assay from our Baroda factory. So there are several examples. I think the important thing is see it as an overall ecosystem and be open to innovate together. For neuroimaging, we work with Indian Institute of Science. So it's largely partnerships and collaborations, I would say. And there are several examples what we do. And like you rightly said, we have proved to the world how it can be done during COVID. And I'm sure some of the best technologies, and while we are a large multinational, you can claim, but we're also creating an ecosystem of homegrown technology players. And the whole intention is whoever makes it better for the world.
Exactly. So I think it's great. We could continue, but I'm sure I'm cognizant of time. But I think the greatest which is coming out is that how do we work together to impact? And anything you can do for 1.4 billion can be replicated to the remaining world. Our strengths on the technology side, on accessibility, on building skills, and looking at, how do you make, because at the end, I think what's changing about healthcare is outcomes, right? When we joined, I think healthcare is about three things. It's about putting in infrastructure, it's about processes, but we forget the outcomes. With GenAI, I think you're going to predict outcomes. Tomorrow, our customer, the patient, is going to say, if I come to your hospital, what are going to be the components? And that's where a resilient healthcare system will outbid others. Thank you, and I thank all of you being a great audience, and look forward to taking this. Thank you.
Delhi Police Security.
लगा हुआ है, हम यहीं पे हैं।
चार उधर हो जाएंगे, चार इधर, बीच में वो बैठ जाएंगे, 5 6
लगवा दो आप।
नहीं 3 15 को बता दो।
उसके बीच में ना कई बंदे आएंगे यहाँ चेक करने के लिए, आप पूरी 9 की 9 लगा के आप तो लगा के सिक्योरिटी वाले आएंगे, 4 बंदे आप भी फ्री हो जाओगे उससे पार्ट। साइड में लगा दो, इस साइड में लगा। मैम 7 चेयर बोल रही है मैम, 9 पर आई थी, बात कर लीजिए। सर 7 चेयर रहेंगी।
Honorable Vice Minister Rajesh Kotecha, WHO Regional Director Saima Wazid, Excellencies, dear colleagues and friends, Namaste. Traditional medicine is as old as humanity itself.
please come in. A reminder to kindly keep mobile phones in the silent mode. Let's not have phones ringing through the session. Just take your moment now to silence your phones, please. Thank you. May I request our panelists to please come up and take their seats. Good afternoon, ladies and gentlemen, esteemed delegates, honored guests. It is my privilege and deep honor to welcome you to this high-level plenary session on traditional medicine and holistic health. That is an important part of the ongoing World Health Summit Regional Meeting 2025. We're gathered here today not just as representatives of institutions, nations, or disciplines, but as stewards of a collective future in health. Our session theme is Restoring Balance, a concept that is both timeless and urgent. In a world still navigating the long shadows of a global pandemic, the climate crisis, and growing inequities in healthcare access, the search for balance between tradition and innovation, prevention and cure, people and the planet is key to re-imaging health systems that are inclusive, resilient, and rooted in both tradition and science. Across continents and cultures, traditional medicine has long been a first port of care for billions. It is embedded in communities, informed by ecosystems, and passed down through generations. It represents centuries of lived experience, local knowledge, and healing practices that have stood the test of time. And today we have a tremendous opportunity. With growing momentum for holistic health and well-being around the world, we can scale access to traditional medicine, embed it responsibly into national health systems, and generate robust evidence that builds public trust and informs modern policy. Today, we recognize traditional medicine to be more than a medical discipline. We see it as a bridge connecting ancestral knowledge and modern science, rural wisdom and urban innovation, the local and the global, and its potential is truly transformative to health equity, access, and well-being for people and the planet. So, ladies and gentlemen, we've assembled a dynamic panel to discuss this game-changing opportunity for global health. And before we move on with the next part of the program, I need to also inform you that apart from hearing our panelists, we will also, time permitting, open the floor to questions from the audience. So do keep writing down your questions so that you can ask them at the opportune moment. When you do ask your question, I'd like to request you to please raise your hand and keep it raised till the moderator, that is our honored secretary, will indicate where the question is going to be taken from. The microphone will come to you, ask your question, state the person that you are or the institution that you represent, and then ask your question. Keep the questions short so that we can accommodate more people and more questions. And then, of course, we've got our panel here that will answer all your queries. To frame the issues, we'd like to begin with a keynote address from the Honorable Minister of State for Ayush, Government of India, Shri Pratap Rao Jadhav, a seasoned parliamentarian and dedicated public servant who has long championed people-centric development through his political career. Unfortunately, Mr. Jadhav could not join us today due to some other unforeseen circumstance, but he has most kindly sent us a video message which we'd like to share with you now.
विश्व स्वास्थ्य समिट की क्षेत्रीय बैठक में उपस्थित माननीय प्रतिनिधिगण, सहयोगियों और मित्रों, आप सभी को मेरा नमस्कार और हार्दिक शुभकामनाएं। यह सत्र पारंपरिक चिकित्सा की भूमिका को वैश्विक स्वास्थ्य प्रणाली में सशक्त करने की एक सामूहिक यात्रा की शुरुआत का प्रतीक है। साथियों, आज पूरी दुनिया गैर संक्रामक रोगों, मानसिक स्वास्थ्य संकट और स्वास्थ्य असमानताओं की वैश्विक चुनौतियों का सामना कर रही है। इसलिए यह आवश्यक हो गया है कि पारंपरिक ज्ञान को आधुनिक स्वास्थ्य प्रणालियों के साथ समाहित किया जाए। अब समय आ गया है कि इस पुनर्जागरण को नीतिगत समर्थन दिया जाए और उसे वैज्ञानिक अनुसंधान और वैश्विक सहयोग से मजबूत किया जाए। साथियों, भारत GTMC के साथ 2 से 4 दिसंबर 2025 को नई दिल्ली में WHO वैश्विक पारंपरिक चिकित्सा शिखर सम्मेलन की मेजबानी करने जा रहा है। यह अवसर हमें एक साथ आने, सीखने और साझा दृष्टिकोण विकसित करने का एक महत्वपूर्ण मंच प्रदान करेगा। अब समय की मांग है कि हम अनुसंधान, नवाचार, पारंपरिक ज्ञान की रक्षा और युवाओं तथा सामुदायिक नेतृत्व की भागीदारी को बढ़ावा दें ताकि परंपरागत वैश्विक चिकित्सा स्वास्थ्य में सार्थक योगदान दे सके। मैं आप सभी को आमंत्रित करता हूं कि आप इस संवाद को दिसंबर में फिर से नई दिल्ली में जारी रखें और वैश्विक स्वास्थ्य संतुलन की इस साझा यात्रा में सहभागी बने। आप सभी को धन्यवाद। जय हिंद, जय भारत।
For the benefit of our friends who join us on the online stream, I shall now read his speech in English. Greetings and warm wishes to all of you. This session marks the beginning of our collective journey to empower the role of traditional medicine within the global health systems. Friends, the world today is facing global challenges such as non-communicable diseases, mental health crisis, and health inequities. Therefore, it has become essential to integrate traditional knowledge with modern health systems. The time has come to provide policy support to this resurgence and strengthen it through scientific research and global collaboration. India, in collaboration with GTMC, will be hosting the WHO Global Traditional Medicine Summit from the 2nd to the 4th of December 2025 in New Delhi. This summit will offer a crucial platform for us to come together, learn from each other, and develop shared perspectives. The current demand is to promote research innovation, protection of traditional knowledge, and the participation of youth and community leadership so that traditional medicine can make a meaningful contribution to global health. I invite you to continue this dialogue in December in New Delhi and be a part of this shared journey toward global health harmony. Thank you all. Namaste. So thank you to the Honorable Minister, sir. We've got our esteemed panel of speakers on stage now, and I'd like to just introduce them to you. It is a privilege to welcome and introduce the chair for this session, Dr. Rajesh Kotecha, Secretary in the Ministry of Ayush, Government of India. A highly respected Ayurveda physician and a visionary in health policy, Dr. Kotecha has played a pivotal role in shaping India's integrative health care landscape. His leadership has been instrumental in advancing global collaborations, including the establishment of the WHO Global Traditional Medicine Center. We are honored to have him guide this high-level panel today. From our neighboring country of Bhutan, we are pleased to welcome Drungsho Dorji Glelsen, a traditional medicine physician in the Traditional Medicine Division within the Ministry of Health, responsible for the implementation and promotion of BTM within the Bhutanese health system. He brings valuable perspectives on harmonizing cultural wisdom with public health to enhance equity and access. We're pleased to welcome Ms. Saima Vazet, the WHO Regional Director for the Southeast Asia region. In her leadership role, she oversees international health efforts across 11 countries, serving a population of more than 2 billion people. Before stepping into her current position, Ms. Vazet held several influential roles in global and national health. She served as the advisor to the WHO Director General on Mental Health and Autism and was a member of WHO's Expert Advisory Panel on Mental Health. Her deep commitment to inclusive and equitable health systems continues to inspire progress across the region. We're pleased to welcome into our midst Mr. Aditya Burman, Director of OnQuest Laboratories Limited, one of India's most advanced clinical pathology and molecular diagnostics companies. With a specialized focus on oncology and genetics, OnQuest has introduced numerous first-to-market assays. What makes his journey even more compelling is the legacy he represents. Mr. Burman is part of the Dabur family, a name synonymous with Ayurvedic excellence and one of India's oldest and most trusted brands. From pioneering health and herbal remedies to expanding into modern healthcare and diagnostics, the Dabur legacy is one of innovation, resilience, and evolution. Bridging this deep-rooted heritage with cutting-edge science, Aditya Burman is part of the team providing strategic direction to Dabur's businesses spread across 120 countries. He exemplifies the future of integrative health care, where tradition meets technology and precision meets purpose. It is indeed an honor to have on our panel the renowned pediatric oncologist and integrative medicine specialist at Charité University, Berlin, Dr. Jörg Seifert. A pioneer in bridging conventional and complementary approaches, Professor Seifert is deeply committed to advancing holistic, patient-centered care across Europe's healthcare and academic institutions, and his work focuses on integrating traditional, complementary, and integrative medicine into modern health systems to foster innovation and sustainability. As a recognized TCIM expert, he brings valuable insights aligned with WHO's global health strategies, and we are honored to have him with us today. We're delighted to welcome Ms. Tanushree Jain, representative of the WHO Youth Council and chair of Public Health of the International Pharmaceutical Students Federation. With her background in pharmacy and her active involvement in digital health and community wellness, Tanushree stands at the intersection of tradition, innovation, and youth engagement in health and well-being. We are indeed blessed and honored to have with us Dr. Soumya Swaminathan, chairperson of the MS Swaminathan Research Foundation and former chief scientist at the WHO. A globally acclaimed leader in science, health, and policy, Dr. Swaminathan has consistently championed evidence-based, inclusive, and innovation-driven approaches. With a distinguished career spanning over 4 decades, Dr. Swaminathan has made outstanding contributions to global health through her work in clinical care, research, and public health policy. I'd like to now invite Dr. Rajesh Kotecha, Secretary in the Ministry of Ayush, to please make the opening remarks and then steer the panel discussion. Okay, sir.
Thank you, Rini ji. Namaste and good afternoon, distinguished panelist speakers, colleagues, and friends from around the globe. It's a great pleasure to welcome you all to this high-level plenary session on traditional medicine, a topic that's not only close to my heart, but also significant to communities and health systems worldwide. Traditional medicine is not just a legacy of the past, it is a living, evolving component of many health systems around the globe. In an era where health systems are striving for resilience, inclusiveness, and people-centered approaches, the wisdom found in traditional knowledge offers both relevance and promise. Our theme of today is restoring balance, scaling up access to evidence-based traditional medicine for health and well-being. The aim is to reflect on the potential and policy priorities of traditional medicine in achieving more inclusive, resilient, and integrated health systems. This panel brings together an exceptional group of leaders representing government, academia, civil society, youth, science, practitioner, and industry, each bringing a unique voice to this global dialogue. I look forward to listening, learning, and moderating this important dialogue. To ensure a thoughtful and engaging exchange, we'll have 2 concise rounds of questions to the panelists, with each esteemed participant kindly requested to share their perspective within 2 to 3 minutes. Then we will open the dialogue to the audience for their questions and curiosities. Thank you. So let's begin by welcoming our first speaker, Dugso. It is actually meaning doctor in Bhutanese. So Dr. Dorji Gelchen or Dungso Dorji, representing the government of Bhutan. Bhutan, we know, that has a long demonstrated traditional medicine, and it can be an integral part of national health system. So Dungso Dorji, we look forward to your reflections on this unique model of integration. My question is, in what ways does Bhutan's traditional medicine contribute to the broader goals of gross national happiness, particularly in promoting holistic well-being and spiritual health and a more integrated approach to public health?
Thank you, sir, for the good questions. The broader goals of traditional medicine on gross national happiness. You know, Bhutan's traditional medicine plays a key role in supporting the goals of gross national happiness, a holistic development philosophy that was introduced by our fourth king in 1970s. Deeply rooted in Buddhist values, gross national happiness prioritizes the well-being and happiness over the economic growth, and is an actually alternative to the gross domestic product, because GDP. Traditional medicine contributes to gross national happiness by aligning with its main 4 pillars. 4 pillars are good governance, sustainable socio-economic development, preservation and promotion of culture, and environmental conservation. By ensuring the equitable healthcare access, especially in rural areas, and builds trust and self-reliance through community-based healing, traditional medicine is already contributing to the good governance. When it comes to sustainable socio-economic development, it provides free healthcare, creates employment opportunities, uses locally available resources, preserve heritage, culture, and promoting the health tourism, by contributing to exclusive growth. When it comes to preservation and promotion of culture, traditional medicine protects the ancient healing wisdom, you know, and spiritual practices, supporting the inner peace and cultural identity. So when it comes to the environmental conservation, it promotes sustainable usage of the natural resources, biodiversity, and ecological harmony, improving the environmental and community well-being. So in summary, I would say, Bhutan's traditional medicine offers a holistic approach that integrates the physical, emotional, and spiritual health, helping to realize the deeper vision of gross national happiness.
Wonderful, Dr. Dorji. Actually, I'm going to ask a question about the Sovarikpa. If audience is not aware about the word Sovarikpa, let me introduce the word. Sovarikpa is a traditional system of healthcare prevailing in all Himalayan states. In India, we have in Leh, right from Leh Ladakh to Arunachal Pradesh, it is being practiced. In Bhutan, it is one of the primary healthcare system of traditional medicine, and it's also practiced in Bhutan. So my question to Dr. Dorji is, with Bhutan's strong foundation in primary healthcare and the integration of Sovarikpa, what role do you see for traditional medicine in expanding equitable access to health services, especially in rural and hard-to-reach communities?
Let me, if I may, briefly explain what the Sovarikpa is to all the audience. Sovarikpa is a science, it is an art, it is a philosophy, and it is also a religion which is interwoven into one fabric and drum as Sovarikpa. In Bhutan, we call it the Bhutanese traditional medicine. So when it comes to the question, the traditional medicine, the Sovarikpa in Bhutan, plays an important role in making health services more accessible, especially in rural and hard-to-reach communities. It works alongside Bhutan's health system, offering very much trusted, free, and very important, culturally relevant care that supports modern medicine. In remote areas, Sovarikpa is actually a trusted choice for healthcare. It offers free, locally prepared treatments based on the ancient wisdom and traditions, knowledge that promotes overall well-being and reduce financial and distance barrier for the people. So with the support of inclusive policies and strong community involvement, this approach strengthens health services and ensure traditional medicines help reach more people, promoting fair access to care for everyone.
Thank you, Dr. Dorji. We have a National Institute of Sovarikpa established by Government of India at Leh. We look forward to have more collaborations with Bhutan from this institute. And now we are honored to have Dr. Saima Vajeji, the Regional Director of CIRO WHO, to share her insights. So my question to Dr. Saima ji is, how will the upcoming WHO Traditional Medicine Global Strategy 2025 to 34 help guide and support member states in integrating traditional medicine into primary health care, particularly to expand equitable access and accelerate progress toward universal health coverage in undeserved community?
Thank you so much. It is really such a pleasure to be here and talk about this topic and be a part of this panel. As you know, WHO's convening power is to facilitate the global medicine, global traditional medicine strategy to help countries develop the evidence-based information, evidence-based programs and planning, and help also get technical data on how traditional medicine would impact healthcare. Traditional medicine has always been part of our culture, particularly in Southeast Asia, and all 11 countries have very robust practices. But the evidence, the scientific evidence, has not evolved in the similar strain as modern day medicine. And so WHO's role is to ensure that we have the right evidence and we identify why many of these traditional strategies actually work so it can be better replicated. It is important that a lot of misinformation, a lot of lack of standardization that exists is mitigated. So the strategy will help ensuring that we can have greater confidence in these approaches. This traditional medicine, we talk about it as, use the term medicine, but it isn't just medicine. It is an approach to treatment on healthcare. It has a big impact on physical and mental well-being. And particularly important is the fact that it is a very cost-effective option for communities where modern-day medicine is less accessible and less available. But at the same time, ensuring that this, the strategy of care, the right kind of strategy of care is provided, requires research, requires technical support, because as we grow the primary health care, as we ensure universal health coverage, we have to give patients, particularly those who are in marginalized communities, hard to reach places, and populations that are financially living in hardship, giving them access to treatment opportunities and health care that is you know, much more sort of socially or religiously, culturally acceptable to them with the right evidence. In addition, the strategy is also focused on making sure that the misinformation or the belief systems that are there can be changed, because oftentimes a lot of we don't realize some of the things that that can interact with medical treatment can actually have a negative impact. So ensuring that this strategy provides a mechanism for health systems to provide guidance to healthcare providers. It will also help in ensuring that there's cross-sectoral collaboration and greater integration, particularly in the primary health system. And most importantly, making sure that there's a people-centered approach and the traditional medicine approach is used in a safe manner so that communities aren't negatively impacted.
Thank you, Dr. Wazed-ji. Actually, you know, having WHO Global Traditional Medicine Center in India, it's under, you know, CERO. It's a privilege probably for the CERO WHO India office. What opportunity is WHO exploring to foster South-South collaboration and capacity building among countries with strong traditional medicine systems in CERO countries?
So, you know, a large part of WHO's work is making sure that the right helpful policies exist. And so this area of medical treatment has always been something that's been sort of outside the typical medical care or healthcare program. So, you know, looking at medicines that is being, treatment that is provided by healthcare professionals or community care professionals that aren't recognized by our healthcare systems. You know, a lot of the times these are, sometimes there are priests, sometimes there are community workers, sometimes they're just traditional medicine providers. So many of them practice and are accepted within the communities, but do not follow the regular guidelines. So for countries, and you know, as you said, it's to have the traditional medicine center, although it's a global unit that it's over here, is so meaningful because in our countries in CERO, it is a part of our life. It's a part of how we live. So making sure that the government can have the right regulatory bodies that are reflective of the realities of the culture and belief systems. Because you can have the policies, you can have the regulations, but communities, particularly marginalized communities, if they don't truly understand and we aren't able to translate the policies into community language and use leaders in the community to spread the right information, the practices will continue. And this is not just for the patients and the end users, but also those who are preparing the medicine. Another big challenge, of course, is that without the right regulatory system, a lot of medicine can be produced that is not standardized. A lot of harmful toxins can be incorporated without knowing it. So all of these very complex strategies have to be well planned, and governments need that support to gather the evidence and make decisions and help implement the policies that are needed so that ultimately the population's health is kept in mind.
Well said, Dr. Wazid. Actually, the gist what you said is that probably these countries will, need the more of kind of hand-holding, capacity building, and having strong regulatory affairs so that they use it in a very effective manner and then get benefited. Thank you so much. Now we have Dr. Aditya Burman. He is the leading voice in Ayurveda. Well said, because I mean traditional medicine-based healthcare industry is a very big industry having a big legacy. His commitment to innovation and public health continues to shape the future of traditional medicine in India and beyond. We would like to hear from you on how do you perceive the role of traditional medicine in Dabur's long-term strategy, and what steps are being taken to strengthen TM as a commercial entity while maintaining its authenticity and effectiveness?
Thank you very much, Dr. Kotecha. I really appreciate the question, and thank you for having me. Look, 141 years ago, our company was founded by an allopathic doctor. Dr. Burman, the original Dr. Burman in our family, was an allopathic doctor. He was not a Ved. He was not a traditional medicine doctor by any means. But he understood something when he graduated. He realized that the success or the speed of the success that allopathic medicine was seeing at that time had a lot to do with a couple of main pillars. Quality, of course, being a big part of things. If you take something and it does harm to you, what good is it? The other is trust, right? So quality and trust, based on these two very solid pillars, the idea of Dabur was created. And Ayurveda at that time was, I would say, as evolved as allopathy is today. As a matter of fact, I feel that Ayurveda, having taken a bit of a backseat in the global conversation, has not had its time in the sun, not had the chance to keep up. And that's really where companies like us come in. We have spent the last 140 years, building on this idea, building on ancient recipes, which the Ayurvedic stamp has to be there only if it conforms to the traditional ways and the traditional recipes. So it's something that we've always had to hold very close to our hearts. I always kind of look back and think, what could have been different, perhaps. And I think that evidence is a big part of things. We hear the word anecdotal a little too much when it comes to traditional medicine, and we'd like to change that. And that's what exactly we've been doing for the last several decades. While we were a Ayurvedic company, which then subsequently grew into an FMCG company, in 1990, my father, who is a PhD in pharmaceutical chemistry, nothing to do with Ayurveda at all, he started a company called Dabur Pharma, which was primarily focused on oncology product manufacturing. So oncology pharmaceuticals, starting with taxanes, going on to platinum products, going on to all the other wonderful products that were developed over time. So the understanding of these two areas, actually the confluence of these two understandings is really where we are today, is that we understand how a body works better than we ever have. And we understand what is inside these mixtures and pastes and the jari booties of our earth. What is it that what is it that can be done? So taking evidence-based literature, taking evidence-based experiences from doctors, combining that with a deep knowledge of biopathways, understanding upregulation, downregulation, understanding scientific evidence creation, clinical trials. These are the things that we feel will be key in bringing this knowledge to the world. There's only so much one can shout it, at the top of one's lungs, unless the other person's willing to listen. It's not really going to get you very far. So this is not about us shouting louder. It's about making the other people receptive. Or when I say the other people, those who do not believe, making them receptive to this idea that traditional medicine actually holds a lot of weight, a lot of water. And for us, the future, is very clear that this is a core part of our belief system in our company. It's a core part of the belief system in our country. And quite frankly, it's not just about Ayurveda per se. Ayush is beyond, well beyond Ayurveda, and I must thank Ayush, the ministry, and sir, for taking all these wonderful steps to make sure that that global trust is growing significantly. The kind of efforts that Ayush is putting in, and I promise I've not been asked to say this. The truth is that, without the support of a body like Ayush, it would be very difficult for companies such as us to be given a platform. Once we have this platform, it's really for us to do with it what we must. We think like scientists, we think like pharmacists, but we apply all that knowledge and that kind of thinking to traditional medicine. And we have seen wonderful things, and we really know that the future is bright for this. Thank you.
It's wonderful, Mr. Burman. Actually, what you said, there is an echoing thing. We have recently, requested NSSO to survey Ayush in our country, in India. And we found through this survey, it's a third-party survey, and we found that 96% of Indian, they are aware about different practices of Ayush, majorly Ayurveda and Yoga. And at least 2.5 million household, one person is doing yoga every day. So this is huge. It showcases the very, very strong undercurrent. And I'm sure that as an industry, you may also have seen such kind of, opportunities in the business. So taking this forward, given the growing global interest, as we are discussing in integrative health solutions, how is Dabur positioning itself to invest in research and innovation in the TM sector, and what are the key areas of focus to drive future growth and expand its market presence? I'm aware that there is a Dabur Research Foundation doing huge work. More insights.
Yes, absolutely. Look, for the last several decades, we've been neck deep in this. But like I said, sir, it's not about shouting louder than the other guy. It's about the other side being receptive. And we understand that. And because of that, we've been spending a lot of time not just working on building products that are effective, but also spending a lot of time proving their effect in a language that is globally understood, right? And like the World Health Organization has got a platform which unifies understanding and knowledge. This is exactly what we have appreciated about the modern healthcare system, the allopathic way of doing things. There is a reason why it took off and did so well. In 1880s, when our company was founded, allopathy was very nascent. Chloroform was still the primary source of anesthesia, and the antibiotics were decades away from being discovered. It was, X-rays weren't invented until after that as well. So there was definitely a parity, if you will. But why did modern medicine, quote unquote, make the journey as fast as it did? Is because of the practices that it followed of getting evidence, of writing it down, of making it publicly available in a manner which can be replicated, right? And that's where the word anecdotal kind of messes with this entire thing. However, anecdotal, the stories that come out of this are the basis, are the starting point. It's the spark that starts the fire, right? Without that knowledge, you can't get an idea. Sitting inside a room, you cannot get an idea. When you're out in an area where there are tribal folks, and we are one of the few companies that have the privilege of being guardians and custodians of India's biological heritage, we take it very deeply that we have to protect endangered species, which are very key in the Ayurvedic practices, right? But to get to these species of plants and whatnot, we have to go far afield. In the field, you find out, as an example, you speak to someone in the tribal area and say, oh, we can't find this particular plant. They tell you, no, hang on, we understand that every few years this plant, it gets less. But instead of that, we use this. Now that's anecdotal, and we might say, oh, frou-frou. But that is the spark that turns around and said, wait a minute, here's something that we didn't know about before. And now what do we do with that? How do we take that plant that nobody's ever heard of? Even the system doesn't know about it because it's such localized knowledge. And how do you take that? Could that be our future cancer cure? Could that be our future cure for depression or cure for obesity or for diabetes? We don't know, right? So this is where anecdotal evidence holds a lot of weight in our minds, but that's not going to carry it across the oceans. Across the oceans is by using proper evidence, by using proper publications, by doing things the way that people expect us to do it, right? Not trying to get them to see our point of view, showing it to them through their own lens. And that's where we get the acceptance. So we've had a lot of experience and a lot of luck with that, and we're looking forward to really, really pushing that over the coming decades. Sorry.
Thanks, Mr. Burman, for putting emphasis on the role of industry in the traditional medicine. Thank you so much. Now, joining us from Germany, we have Dr. Jörg Seifert. He's a pediatrician and professor at Charité University, Berlin. Ayush has a long association with Charité University. I fondly remember a few research projects we did together. His experience in integrative and holistic health systems offer valuable lessons from Europe's evolving approaches to patient-centered care. Based on his expertise and experience, I would like to ask you, Doctor, from your perspective as a clinician in holistic health, what are the most important research gaps for integrating traditional medicine into holistic healthcare models? And how can we reconcile the need for scientific evidence with the personalized, experiential nature of many traditional healing approaches?
Yes, thank you very much for this interesting question. And I'm a clinician that feels at home both in conventional medicine as well as in traditional healing systems. And I see the advantage of traditional medicine in general as a vital, under-researched pillar of future healthcare in general, also in modern healthcare system. And its core strength lies in prevention, I would say, lifestyle-based interventions, and empowerment of patients. And to fully integrate these strength into holistic care models, we urgently need more research, particularly in the field of healthcare service research, in the field of cost effectiveness of real world evidence and long-term observational studies. And also the question of sustainability, like climate-friendly medicines and health solutions, is something where I see a lot of resources in the field of traditional medicine. But integration in general, from my point of view, requires way more than data. Some of the panelists already mentioned that it requires trust, and trust between traditional and conventional clinicians, researchers and the both kind of systems. But trust doesn't come so easily. Trust grows from a real kind of honesty, I would say. And that's an important point. I think we have to be really transparent about both the strength and the limitations of traditional approaches. That's something really important. Not everything that is called traditional is inherently effective. But many traditional practices are meaningful, are safe, and offer valuable synergies when used wisely and integrated into a scientific and a good clinical setting. That's something important. So our goal, I think, has to be not to force traditional medicine into rigid scientific molds, but to expand our research paradigms so that we can capture like what truly matters to patients, like feeling better, quality of life, staying healthy, and the perspective on the whole person. That is especially something that we in modern healthcare systems are missing in a way. And I think it's also essential to recognize that the individualized relational nature of traditional medicine does not contradict evidence-based practices. With modern technology like N-of-1 trials, patient-reported outcomes, qualitative research, we can scientifically study these complex interventions and person-centered approaches. That is something that works, and we have means to that. And the goal is not to standardize everything, but to understand what works, for whom and why.
Thank you. It is very insightful. Actually, you mentioned about the whole system approach in traditional medicines, and then taking it to the personalized care, and there is possibility of having convergence. So, do you see, Doctor, the opportunities for cross-cultural collaborations to co-create integrative care models that are both evidence-based, evidence-informed, and rooted in traditional knowledge?
Well, absolutely. I think medicine has always been kind of trans-cultural enterprise, and across countries, across borders, medical knowledge has been exchanged along trading routes between civilizations and so on. So the richness of traditional medicine systems, from Ayurveda to Chinese medicine to European therapies, is actually an important wealth of our shared medical human heritage. So today we have a unique opportunity to revive this spirit of global collaboration in the field of traditional medicine. I think I can envision a global network of integrative clinical centers that evaluate diverse care models using rigorous but flexible methods, clinical methods tailored to cultural and therapeutic contexts. And of course, it's quite ambitious to do something on a global level, but it's also, from my point of view, a tremendous opportunity to combine this richness of global traditions and experiences with the rigor of modern science to create a healthcare system or data that are pluralistic and inclusive and first of all also sustainable and in line with the SDGs. So why not developing a shared global outcome framework, flexible enough to capture everything, to capture the complexity of healing systems, but on a scientific basis. And of course, such a framework has to focus on common values and be measured through transparent and widely understandable indicators. So it is actually a strength that can inspire innovation and foster resilience and help us to build a healthier, future-rooted system, healthcare system, culture rooted on cultural wisdom and scientific insights into the molecular details.
Thank you, Dr. George. Actually, to add what you said, that there is a publication of the morbidity codes of Ayurveda, Siddha, Unani in ICD-11 traditional medicine chapter, which is probably the pathway what you said to have this integration or this generation of the data-driven evidences, etc. So this is one wonderful thing that has happened at the WHO platform. Thank you so much. To bring in the voices of next generation, now we have Tanushree Jain, a novel young pharmacist and health advocate. I personally believe youth comes with a vision on innovative thoughts for the sector, any sector. So, question for you, Tanushree, as a youth leader, how do you believe today's generation views the importance and value of traditional medicine systems in promoting holistic health and well-being?
Thank you for the question. I'm very grateful to represent the youth voices in this panel today. Thank you to WHO for providing this opportunity. Across the world, we are witnessing a generational shift in how young people define health. For us, as Gen Z and millennials, wellness is no longer just about treatment. It's about balance, prevention, mental well-being, and sustainability. Traditional medicine, whether it is Ayurveda in India, Campo in Japan, or indigenous healing systems in Latin America, is increasingly seen by youth as a legitimate pathway to personalized and preventive care. A 2024 survey by McKinsey showed that over 65% of Gen Z globally engage in wellness activities weekly, with rising interest in natural remedies, mindfulness, and non-pharmaceutical interventions. But we also carry high expectations. This generation seeks evidence, transparency, and ethics. We believe in ancient systems, but want to see them validated through science and integrated safely with modern care. When traditional knowledge is adapted with rigor and relevance, it earns our trust.
Thank you, Tanushree. Actually, this is we also came to know the expectation from the millennial. How can technology be used to make traditional and holistic health approaches more accessible and relevant for young people?
Technology is transforming how young people access and engage with traditional and holistic health approaches. Digital tools like mobile health apps, fitness trackers, and interactive online platforms make traditional practices more accessible, personalized, and relevant for today's youth. For example, projects such as the EU's YA initiative integrate fitness tracking, social media modules, and discussion forums to promote healthy habits and reduce health inequalities among adolescents. Health apps and gamified learning platforms encourage engagement by making wellness education interactive and fun, supporting behavior change beyond traditional doctor-patient interactions. These tools can offer personalized wellness plans, virtual consultations, and real-time feedback, helping young people integrate holistic practices into their daily lives. Social media plays a crucial role in enhancing health literacy by providing real-time access to trusted information, fostering peer-to-peer support, and building communities around holistic health practices. Campaigns and influencer content can demystify traditional medicine, making it more appealing and understandable for digital natives. However, to ensure authenticity and equitable access, it's important to establish strong guidelines and foster collaboration among practitioners, technology developers, and policymakers. When thoughtfully integrated, technology not only preserves the relevance of traditional medicine, but also empowers young people to take charge of their holistic well-being in a way that is engaging, inclusive, and sustainable. One of the examples that I can give through the work that WHO Youth Council has been doing, our primary vision is to advise the WHO leadership, especially the Director General. And in one of the advice that we have included, upcoming advices, is that all the toolkits, all the information, and all the resources that are put out by WHO should be accessible by youth and children in a language that they understand, in summaries that they can understand, whether it be through shorter content, whether it be through caricatures or other tools used by the WHO and other international organizations. Thank you.
Thanks, Tanushree. Very insightful. Actually, this is really appreciated. Now we turn to Dr. Soumya Swaminathan-ji. We sincerely acknowledge, Soumya-ji, your contribution for the establishment of WHO Traditional Medicine Center in India. I remember that it was an outcome of your detailed discussion with the DGWHO when you were Chief Scientist at WHO. She is the chairperson of MS Swaminathan Research Foundation and also former Secretary Government of India at Department of Health Research. I fondly remember working with you. As someone leading impactful work at the intersection of health, science, and community resilience, we are eager to learn from you. My question is, how can WHO better bridge the gap between science and policy in traditional medicine to ensure that culturally significant practices are evaluated and integrated using robust, context-sensitive scientific methods?
Thank you very much, Rajesh-ji. And yes, I think one of the good examples of how the two systems of medicine can work together is when I was DG ICMR and Dr. Rajesh Kotecha-ji had become Secretary of Ayush. We met and immediately decided that we should evaluate certain promising treatments in Ayurveda for conditions for which allopathy doesn't have a very good solution. Because the first thing to accept is that no system of medicine really has the answer to everything. And this is why we need to think about integrative medicine. But in practice, integrative medicine, I think, is very rarely practiced. We probably have very few examples of truly integrative medicine. But in this case, we took on, and ICMR has had a long history, even before this, of evaluating Ayurvedic remedies and through randomized clinical trials and proving the efficacy of interventions for things like anal fissure, for diabetes. And then we were looking at drugs for dengue for people who were hospitalized with dengue and a couple of other conditions. So I think bridging the two first requires a common language and vocabulary. And that's one of the things that WHO can do very well, and it's one of the roles of WHO, is to create those normative frameworks. And Dr. Geeta Krishnan is here, and he was my colleague in WHO, and one of the things he took the lead on was creating that vocabulary of standardized terminologies which can be linked to the ICD, the International Classification of Diseases. This is something that Chinese traditional medicine had already done. And it takes time and effort, but with a lot of support from the Government of India and Department of Ayush, this was accomplished. So one is because then you have to compare apples and apples when you're doing studies or you're talking about treatments. You need to know what condition you're referring to and what the endpoints are. So I think that's the first thing that we need, because Veds would use a very different vocabulary from what we would use, very different diagnostic systems and so on. So who's going to do? So I think that's maybe for WHO, and if there are national bodies that can do that, then that is the first step. The second is designing the studies and the clinical trials, because again, it's about the language that we use and the experiential nature of some of the traditional systems of medicine. And in allopathy, we used very, clear-cut, we think it's clear-cut terminologies to define various conditions, outcomes, etc. So how do you, so for this you need a dialogue and you need a open mind on both sides to be able to develop this framework of how do you design and implement a clinical trial. And I think what we ended up doing was to say that it was truly integrative, I think, that the patient would be evaluated by both an Ayurvedic and an allopathic physician, and there would be outcomes documented, and then the results of the trial could be analyzed. So it requires a deep understanding and collaboration. The third, of course, is in the area of modern tools that we have today that Aditya was also referring to. We should be using them in a sensible and insightful manner, whatever omics we want to talk about, whether it's genomics or measurements of other biomarkers in the blood, and now we have so many imaging modalities. There have been lots of sessions here on the use of artificial intelligence, both for diagnostics as well as to evaluate outcomes. So we should use the tools that are available to us today, but again in a manner that makes sense to both sides, practitioners of traditional medicine and practitioners of modern medicine, because it can also, of course, tell us about the pathways and the mechanisms of action, because again, modern medicine is in a way a reductive science, in the sense that we need to pinpoint the plausibility through the biological pathways of action. And a lot of research done in India has shown that, and Ayurgenomics is a good example, Mitali is here also in the audience, where, and I'm sure you're doing a lot of that kind of work as well, where you're looking at the pathways, whether they are molecular pathways or to establish. Because even the drugs we use in allopathy, 40% of them actually came or more came from plants. And they were, and you know, Dr. Yu Tu, the Chinese Nobel laureate, was somebody who screened thousands of herbal medicines that had been used in traditional Chinese medicine and discovered artemisinin. So and we can name so many drugs that came and come from plants, you know. So there is a huge opportunity and science out there, as you say, listening to the local people's experiences of using, and then taking that anecdotal, so-called anecdotal evidence into the more scientific pathway of drug discovery. If done systematically, I'm sure could yield even more molecules in the future. Similarly, there are many foods which have, you know, functional properties, bioactive molecules, and things which have yet to be discovered, which traditionally people may know that eating certain foods, you know, gives you these effects, but perhaps we haven't gone into the details of why that could be happening. And cooking and the ways of preparing food also can alter the properties. And I think Ayurveda is, again, that's why very you know, particular about how you should eat, when you should eat, what you should eat, in what order, and things like that. So I think that the role of the WHO also could be to coordinate studies, to coordinate trials, to have a system of hub and spokes, perhaps, of integrative medicine, because I think it is really the need of the day to have that type of approach. And I remember during COVID, the Solidarity trial that we ran, of course, at that time it was a global pandemic, an emergency, but we wanted to get evidence quickly on the efficacy and safety of certain drugs that were being proposed by different groups of people, like hydroxychloroquine, for example, because there was some lab evidence of activity against the virus, but a lab evidence in a Petri dish doesn't translate into clinical benefit always. So you have to do the clinical trial. So we had 4 or 5 such drugs that were being proposed as antivirals. And the Solidarity trial was mounted very quickly. It was run almost entirely digitally with very little cost. And within a few months, we had evidence of mostly lack of efficacy, except for the case of dexamethasone, of course, which proved to be highly effective. But it gave us a very good evidence base to build our treatment programs on, because you certainly don't want to be using things which are ineffective. You want, because resources are not unlimited. So the resources have to be used to create clinical benefit or improve public health outcomes. And so that's where I think the scientific approach, which I would say that Ayurveda is certainly not against, or any of the traditional medicine systems. And I must appreciate Bhutan also for the gross national happiness. I wish more countries would adopt, because I think the path of development that we are pursuing now is probably not going to lead to gross national happiness in most countries. So I think if you focus on these 4 pillars that you talked about, particularly biodiversity and paying attention to our environment, which is where most of our risks to health and the determinants of health are coming from today, I'm sure our population will get healthier.
Thank you, Soumya ji. Actually, you have started that, and then your colleague from WHO, who is now the Secretary DHR, Ayush is working with them, and there is a large trial on a particular candidate on anemia is going on. Very large, it is a multi-centered placebo-controlled trial is going on. We are hoping that it will provide some solution. Another thing is that, if you remember, we have this visualize that can we have a joint establishment of integrative research centers in India. It has been done. So there are such Ayush ICMR Advanced Center of Integrative Research is established in different aims. So this is an outcome of what we thought a few years back. So thank you. My next question is, with the growing interest in AI, digital health, and omics technologies, how can these innovations be harnessed to accelerate the validation, safety assessment, and personalization of traditional medicine practices and products?
Yes, I mean, I think this is an opportunity that we have today, because till a few years ago, I don't think we had these kind of access to these kind of tools, whether it's in the digital tools and the AI, which is so advanced now and advancing every day, or to be able to look at the kind of biomarkers that we are able to, and these things are becoming more cost effective. So I would say that, without going into too much of detail on this, what we really need is a multidisciplinary and an interdisciplinary, because we also have now this the data science as a discipline, because what you can get is insights from large data that a human being may not be able to see, but AI can actually find out patterns and associations from big data. And then that can be further used by scientists, to validate. So to create hypotheses, one can use AI. Now, to do that, you first need the data set. And that's where the issue comes, because I think that there are few places perhaps which have very good electronic health records, but majority of our centers, hospitals and public health outposts do not have good. We're starting to develop those electronic health records. So maybe in a few years, we will be able to. So I think the elements will be even for these integrated centers, would be very important to have electronic health records, which you can then track a person's health over a period of time. AI, for example, could be used for an individual to, when they go home, to actually record what they're experiencing in terms of their well-being or not being well. When they're at home, you could talk into your device, your phone, and the AI actually does create a record of all of that. So in between your hospital visits, when you're not seeing the doctor, what is your status of well-being? Actually, there are companies I know that are trying to work on things like that. And then, of course, you could if you're really delivering integrative health, it means that the doctors of the different disciplines are sitting and talking to each other, which right now may not be happening in too many places. I mean, I think in primary health centers, you do have an Ayurvedic doctor sometimes, or a Siddha doctor sitting, but in a different building. And so that is not true integrative, right? I think you have to sit and plan the person's. That's when it becomes real person-centered and integrative care. Of course, it takes time, and there's always a shortage of time in the clinics. So I think interdisciplinary and multidisciplinary teams are needed to do this kind of work. And we could use now data scientists and people who understand AI really to look at whatever large data sets we are able to collect. This could be from allopathic hospitals, Ayurvedic hospitals, and those kind of things. I think that kind of analytics would give us great insights now, which perhaps was not possible earlier.
Very insightful, Dr. Soumya ji. Actually, just to add, recently India has, taken this responsibility of leading a talking group of AI in traditional medicine among this WHO ITU group of AI in health. So thank you, Dr. Soumya ji, again. Now we have one last final question. It's a fire round. One question to all of the panelists. I will start with Dr. Dorji. And my question is, looking ahead to the next 5 years, what is the one thing that is needed most for traditional medicine to advance the health and well-being of all?
In next 5 years. Over the next 5 years, the key to advancing traditional medicine is establishing Bhutan as a center of excellence in Sawarikpa, the center of excellence in the region and beyond. By focusing on the sustainable and innovative practices, we will preserve and promote Sawarikpa, and very much ensuring it remains relevant, accessible, and contribute to global health.
Thank you. Now it's turn of Dr. Saima Wazid ji. The same question, looking ahead to the next 5 years, what is the one thing that is needed most for traditional medicine to advance the health and well-being of all?
Well, this is a very exciting time to be regional director of WHO because, in the next 5 years, given the advancement now and the recognition traditional medicine has, and the practices that exist in countries, what we hope to do is to bring that data together and bring some common knowledge and shared knowledge in a standardized format. And so that what exists is, what the knowledge that exists in communities, in individual countries can come to a global platform and be shared across. And that is really, where the change has to be, because traditional medicine is all about well-being. It's holistic. Particularly, this impacts mental health, because in many ways, modern-day medicine has not always been able to address mental health care needs. It's, of course, very important for vulnerable populations where modern-day medicine isn't always easily available. But we also have to look at the particular population. When it comes to women's health and children's health, a lot of medicine have side effects or cannot be taken at certain times. When a woman is pregnant, there's not a lot of access to medicine. So taking all of this information and practice and bringing it into a well-being structure through generating the evidence and creating the standards so that governments and policymakers can have national plans and they can have national policies, but also the right evidence that they can believe in. So that's what we hope to do.
Thank you. And Mr. Aditya.
The next 5 years, very true. It's going to be an absolute wonderful time for traditional medicine. What is the one thing? I think there's a lot that we can do, people on this panel, scientists, people in healthcare. But there is the softer aspect of things. Again, going back to the recipient of this information, I think that there is the kind of rhetoric when it comes to things such as cinema, TV shows. I'm probably showing my age on this, but Grey's Anatomy, if they were talking about introducing something from Ayurveda into one of the protocols, these are the things that catches the imagination of the world, right? It's not just this one weird out there idea that, you know, sure, one day when it becomes exactly what I'm expecting, that's when I'll take it. It has to start becoming a part of the global nomenclature, you know. How is it that people are viewing this? It's not just a matter of, you know, getting all the scientific proof and all the thick dockets of information, though that really helps getting it there. But when the people are ready to receive, I think that'll be a huge change. It's a bit of PR, a bit of marketing perhaps, incorporated with a lot of great science and a lot of conviction on our part. So I think from our side, you know, we will do scientifically and medically what we can, but on the other side, you know, we hope that this, the rhetoric switches into our favor, and we can do a lot about that as well, I feel.
Perfect. What about you, Dr. Seifert?
Now, since I come from Germany, and for the first time, traditional medicine and integrative medicine is in the main agenda of the government and the new coalition that is in power, I see the big potential in the field of prevention and integrative models. But to be honest, we need strong evidence, and we need also good business models that are evaluated and that show an advantage in terms of cost effectiveness. I think everything else doesn't make sense since especially our healthcare systems in Europe are actually too expensive and not effective enough, especially if it comes to NCDs.
So two messages is a high-end evidences and good business model, I think. Thank you. Dr. Tanushree?
I see that in the next 5 years, as young people are already adopting traditional medicine in large numbers, that they are also more involved in advocating for the demands that they are looking for, to establish that anecdotal evidence into scientific evidence, into research evidence, and to build that trust in the traditional medicine that we all are talking about. Thank you.
Thank you, Tanushree. Dr. Soumya-ji?
Yes, I think that, you know, the whole world is now talking about One Health. And even in the context of pandemic preparedness, the pandemic treaty that's just been agreed to, historic occasion by the member states, talks about one of the elements there is One Health in pandemic preparedness. So I think One Health is nothing but, you know, taking care of your environment, thinking about other species, whether they're plants and animals, and using them, you know, in a way in which you can promote also human health and well-being. So I think that maybe different things are converging now, and as everyone else has said, this is the time really to come together, to bring the disciplines together, not fight over which one is better, or, but to really develop the science and communicate it effectively to people, so that you're really talking about delivering the best person-centered care for that individual, because ultimately that's what the person who comes for care actually wants, is that they should get better, they should have a sense of well-being. They don't look into what you're prescribing. They'll take whatever the doctor's, you know, telling you to take. But the issue is, as health professionals, can we, you know, really put aside those differences that we've had in our training and so on, to actually come together and think about the individual and the family and the community at the end of the day and do the best for them. Thanks.
So two messages, person is at the center and One Health. Thank you, Soumya-ji. Now we have some time left for the participation of the audience. And, you know, maybe we can raise our hands and then we start from you, sir, here at the second row. Yes.
Sir, as a patient,
please use the mic, sir.
Severe health crisis face किया हो last 30 साल.
Please introduce yourself also.
सर मेरा नाम गिरीश अग्रवाल है. मैं चार्टर्ड अकाउंटेंट हूँ बाय क्वालिफिकेशन, और जॉब भी मेरा फाइनेंस में ही रहा.
योर क्वेश्चन?
क्वेश्चन मेरा हेल्थ और वेलनेस से इसलिए है कि मेरी हेल्थ बहुत सीवियर हेल्थ क्राइसिस रहा 25 से 30 साल लगभग, जिसमें फर्स्ट जो था बेसिकली साइकोसोमेटिक था सारा केस. मेरा मेंटल और इमोशनल बैलेंस डिस्टर्ब हो गया था, जिसकी वजह से
एक्चुअली अब हम जो जिस सेशन के संदर्भ में कुछ हो तो बताइए.
हाँ, सेशन के संदर्भ में है जहाँ पॉलिसी और रेगुलेटरी है और एविडेंस के ऊपर है. जैसे अभी मैं 22 में पलक्कड़ गया था, सारे टेस्ट हुए थे, उसमें कुछ नहीं निकला था टेस्ट के अंदर, जहाँ तक एविडेंस बेस्ड का सवाल है. और सीवियर डिप्रेशन था, सारे डाइजेस्टिव इशू गड़बड़ था, सिर्फ एक विटामिन डी में थोड़ा सा कमी आई, मतलब ठीक ठाक कमी थी, और किसी भी पैरामीटर में कमी नहीं थी. एविडेंस बेस्ड वाला जो एंगल है. जो मेरा पॉलिसी और रेगुलेटरी के एंगल से जो पहला क्वेश्चन है जो मैं फेस कर रहा हूँ, मैं कोटक्कल में एडमिट रहा दिल्ली में कड़कड़डुमा 15 दिन, ठीक है. तो वहाँ डाइट का इशू था, और दूसरा था पंचकर्मा ओपीडी के रूप में कहीं अवेलेबल नहीं है. मतलब हॉस्पिटल में एडमिशन होने का मतलब है बहुत एक्सपेंसिव है.
सर आपका ये इश्यूज है ना, मैं आपको पर्सनली बात करके रिजोल्व कर सकता हूँ, है ना, ठीक है ना.
और इसके अलावा एविडेंस बेस पे सर एक क्वेश्चन है, एविडेंस बेस
आप
पे
एक
सेंटेंस में फॉर एग्जांपल रिफाइंड ऑयल के पहले कोलेस्ट्रॉल की रिसर्च आई ओरिजिनल, जो बाद में रिवर्स हो गई, और आज भी रिफाइंड ऑयल चल रहा है हर जगह पे. तो एविडेंस का क्या मीनिंग हुआ फिर?
सौम्या जी आप कुछ रिस्पॉन्ड करना चाहेंगे इसमें?
हाँ, तो जो डाइट की बात है उसमें तो बहुत चीज़ें हैं जिसमें जा सकते हैं हम डिटेल में. तो इसमें हेल्दी ऑयल्स कौन से हैं, अनहेल्दी कौन से हैं, अफोर्डेबल क्या हैं, कई सारी चीज़ें हैं. बैलेंस डाइट होना चाहिए बेसिकली, तो उसके ऊपर बाद में चर्चा करेंगे.
हाँ, यस.
Hi, I'm Pooja Jha, Editor-in-Chief, The Lancet Regional Health Europe from Munich, Germany. And as an editor of a leading publishing house, I have two questions. One is, we hardly publish anything on traditional medicine. And one reason is because, as Dr. Swaminathan, you mentioned, we are heavily focused on reductive science. So the way we evaluate has to be very high power, statistical, and robust science. And therefore, perhaps a lot of traditional medicine papers do not fall in the realm of what Lancet publishes. So my question is, what can you suggest to us as editors of Lancet? What can we do to bring traditional medicine at the global stage so that people have trust in traditional medicine? And the second question is that we don't publish a lot because we don't receive papers, high quality papers on traditional medicine. So my question is, why don't we receive papers, high quality clinical trials on traditional medicine? Thank you.
So your second question pertains to the audience, because the stakeholders are sitting here. It is challenge to them that why you are not submitting high quality publications and for the publication in Lancet. I would request again, Aditya ji, if you want to respond.
If I may, actually, I think one part is actually expense. It's expensive to submit something to an international journal. And I'm sorry, I don't mean you specifically or any journal specifically. It's just, you know, the traditional medicine, you know, it happens at a level where, you know, the expense of going through and getting something ready for that global stage is very difficult. So perhaps if there was some, you know, program within some of these, you know, such wonderful publications that bring the knowledge to the world, to actually incorporate some of those things, you know, that idea into it, it would be super helpful. And the other part is that language, I feel, has also been quite a challenge, right? So for somebody who is in a rural part of India, who has this knowledge and has done some research and could perhaps get funding together to run a trial, very often, you know, it's a language issue, it's a culturally sort of understanding what the other side wants issue. So yeah, I think outreach from you know, the side of the publishers, but of course I think the government and the powers that be should also perhaps create a platform which allows for this. And I think AI is going to help a lot with that, especially with things like language. So yeah, sorry.
If I can just add one more part. I mean, you've already heard about anecdotal information, qualitative research, right? So in medical science, we don't really value qualitative research or mixed research design. But one of, in addition to all of this, one of the other challenges is to get published in a peer-reviewed journal, you also have to have the right references, right? So if you don't have other research to reference, you can't really validate. So journals or peer reviewers are going to say, okay, what are they basing it on? So you've got a combination of language, you've got a combination of the practices that we have, but also publication policy and methodology that's set in a way that we all accept and acknowledges the correct way, but it doesn't quite fit in with this particular topic. So I think one of the things we would need is for journals to also create the opportunity. So if that opportunity is created, you will have research publications, and that will help generate people who are interested in working in this area to follow up and do further research.
Thank you. Probably adding some human resource into your editorial team from traditional medicine will also help. Yes, please.
Yeah, my name is Angela Brandt from Maastricht University and Manipal. I have been trained as a medical doctor, pediatrician, and as a clinician in Germany, then worked in evidence on health technology assessment, and then in Mahe. Over the last 12 years, I learned a lot from Valia Tanzer about Ayush biology and really the very holistic, individualized way to look into medicine. And when we see now our Western medicine, in the end, the evidence is more or less 50%. That's nothing. Then we see the growing scientific knowledge coming from Ayush biology, applying the omics by microbiome enabling technologies, and we have amazing results. So my question is, or my suggestion is, I think we should integrate the Western medicine in the traditional medicine. And the start, because we are not in the Western medicine, we are still stratified. And we will never get to individualize, to personalize what we want to, where we want to go. So to really start with traditional medicine and avoid the systematic bias what we have with stratified medicine in Western world. That would be really my wish.
Thank you. Actually, Ayurveda biology program, you know, it was initiated from Manipal University, and thanks for that contribution. And this is, your suggestion is well taken, and it's like integration of modern medicine into the Ayurveda. You can consider going to All India Institute of Ayurveda in Delhi, which is a living model of such types of integration. Please, here. इस दिशा में भी देखना चाहिए.
Hi, I'm Sparsh. I run a pharmaceutical manufacturing and exporting entity. So my question is primarily that the medicine works on the basis of confidence of healthcare professionals. So how are we moving ahead in the infrastructure part of developing more healthcare professionals focused towards the traditional medicine?
So who wants to respond? Maybe I respond. Actually, this is a question which comes as a country-specific question, you know. So we are sitting in India, so I can respond from India perspective. So in India, there is a very, very, you know, strategic investment happening in the health sector by creating ecosystem, new education institutions, new aims, number of medical seats, number of Ayush colleges, etc. It's already going on, and a great transparency and innovation in education is going on, and it is being visible over the period of years. And you are right that, you know, investing in infrastructure and human resource is the core thing of the healthcare industry or healthcare sector. May I invite Ravi Acharya for, you know, if he wants to ask some question. काफी देर से आप हाथ खड़ा कर रहे थे कुछ.
Just
to
नहीं, respond न करिए आप, respond करने का काम यहाँ है.
No, you have asked na from the audience side regarding why the articles are not being published in a good Lancet.
Short.
Very short, sir. We need that Lancet should have, because at the outrage they reject the article. We don't have reviewers. The first question, we don't have our policy does not adopt, and we don't have reviewers. So I want to say that now Ayush and particularly traditional medicine, WHO is concerned, we have a good amount of research work being done and being published. So let us have your policy to adopt this type of traditional medicine being published in our journal. That's my suggestion.
Yeah. Maybe last, Mitali, she also raised her, this is last question.
Just a comment that One Health framework is implicit in Ayurveda because it maintains biodiversity and it maintains the context-specific food, everything. But I do not see in the country's programs, Ayurveda has been integrated into the One Health framework in the ICMR setup. So I think I would like to know the comments because the way the medicines are sourced is locally and contextually. And you have so many ways to arrive at the same outcome. So I think there has to be some deliberation on integration of Ayurveda into One Health framework when these studies are being conducted.
So Mitali, it is going on. One Health is being moderated or taken by or driven by Office of Principal Scientific Advisor of the PM. And Ayush is integral part of One Health mission. So in NIOS also, Ayush is there and it is being taken up. So I think we have, I suggest that rest of the questions, because after this event we will have, some free time. So the curious audience who has some more questions they can ask. And I'm so happy that this debate, this panel discussion has created a lot of curiosity. There are a lot of questions still pending, but due to lack of time, we have to close this session. And I hand over the session to Rini.
Thank you, sir. Thank you very much. All those who have questions, please do come up at the end of the program to ask those questions. Let it not just go unasked. Thank you so much to the esteemed panelists, our guests and participants for being part of today's meaningful dialogue. The depth, the diversity, and of course the vision that was reflected is truly inspiring. We now have the honor of hearing from Dr. Tedros Adhanom Ghebreyesus, Director General of the World Health Organization. His leadership has been instrumental in placing traditional medicine at the heart of the global health discourse, not as an alternative, but as a vital, evidence-informed part of universal health coverage and the planetary well-being. So it is my honor now to invite Dr. Tedros to deliver his remarks.
Honorable Vice Minister Rajesh Kotecha, WHO Regional Director Saima Wazid, Excellencies, dear colleagues and friends, Namaste. Traditional medicine is as old as humanity itself. For hundreds of millions of people, traditional medicine is just medicine. 2/3 of WHO member states report a significant use of traditional, complementary, and integrated medicine among their populations. Through the WHO Global Traditional Medicine Center in Jamnagar, we're supporting research to harness the power of these ancient practices. Bringing innovation, data, and partnerships to bear, we can increase the impact, improve safety, and protect biodiversity. At next month's World Health Assembly, WHO member states will consider and hopefully adopt the new global strategy for traditional medicine. And in December this year, we will hold the second WHO Global Traditional Medicine Summit in Delhi. The summit will be an opportunity to announce new commitments to implement the global strategy and invest in research. I thank His Excellency Prime Minister Narendra Modi for his leadership and partnership in traditional medicine. And I thank all of you for your commitment to bringing ancient traditions and modern innovations together for health for all. I thank you. Namaste.
Thank you, Dr. Tedros. Your message today is a powerful call to action for all of us. So as we look forward, it is clear that this is not the conclusion of our conversation. It is only the beginning of a shared journey, a journey that is as much about restoring balance within ourselves as it is about restoring balance in our communities, in our health systems, and in our relationship with the natural world. So that journey, ladies and gentlemen, continues at the second WHO Global Traditional Medicine Summit from the 2nd to the 4th of December 2025 in New Delhi, as Dr. Tedros had just mentioned. So let's together take a look at the closing video on the second WHO Global Traditional Medicine Summit.
How do we find balance? We find it in tradition, in practices that honor indigenous knowledge systems, offering unique perspectives on health and well-being. By bringing together centuries-old wisdom and cutting-edge science.
I think it's important that we realize that conventional and traditional medicine can go hand in hand.
Traditional medicine is not a thing of the past. There is a growing demand for traditional medicine across countries, communities, and cultures.
What we do need is to have a really strong, forward-looking, progressive way of being able to recognise the medicines of millennia.
The holding of WHO Global Summit on Traditional Medicine will intensify efforts to harness its potential.
The first WHO Traditional Medicine Global Summit set a baseline for action. A foundation of progress, data, and new technologies to unlock the full potential of traditional medicine. The 2025 Global Summit presents a pivotal moment to take this even further, expanding the evidence base for scientific innovations in traditional medicine. Recognizing the unrelenting instability in the world today, the summit will center around restoring balance, accelerating conversation and collaboration on topics like biodiversity protection, intellectual property rights, and the potential of AI, including the launch of the WHO Traditional Medicine Global Library. Join us as we explore how the nexus of traditional medicine and modern science can restore balance and well-being for people and our planet.
So, ladies and gentlemen, our upcoming summit in December will be a gathering of extraordinary minds and voices, knowledge holders, scientists, youth leaders, innovators, policymakers, and community representatives coming together in person and online to shape the future of traditional medicine in the context of equity, sustainability, and resilience. As we come to the close of this session, we warmly invite each of you to participate, not only as attendees, but as co-creators of the future we aspire to. Because restoring balance is not just a policy goal, it is a personal and planetary commitment. So once again, thank you for your presence, for your passion, and for your partnership today. We look forward to seeing you in December, refreshed in spirit, united in purpose, and ready to carry the momentum forward. Thank you. Namaste. Could we get the WHO team to please come up for a group photograph? Mr. Kotecha, may I request you to please remain on stage? WHO team, please quickly come up on stage for a photograph. WHO team, please quickly come up. Thank you, Consul.